I would like to call the June 4th, get out of here, 2013 Longmont City Council study session to order. Could we please start with a roll call?
Mayor Coombs.
Present.
Council members Bagley, Finley, present. Levison, here. Samori, here. Santos, here. With, here. Mayor, you have a quorum.
All right, let's stand for Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, public invited to be heard. The first person on the list is Jeff Zayak.
That works better. Mayor Coombs, City Council members, thank you for allowing the public to be heard. I am here on behalf of item 4B tonight, which is, and I'm sorry, my name is Jeff Zayak. I'm the Public Health Director with Boulder County Public Health.
And what's your address?
Sorry, 3450 Broadway, Boulder, Colorado.
Thank you.
And I'm here for study session item 4B, the Longmont Community Health Network. And I'm here to offer my full support for the work that's happening. I want to say just a few things about this that I think are important. Number one, I want to thank, and I think Mike Butler deserves special recognition. He recognized that this was a health issue and an economic issue, not just for the services in the community of Longmont, but for the people of the community of Longmont. And he took the leadership role to actually help pull folks together to address this issue in a way that makes perfect sense and is economically sound. I also wanted to acknowledge a few other partners that have helped. I know you have a full packet, and I just want to highlight a couple things that I think are critically important in terms of this effort in this partnership in our community. And one of those things was from Longmont United Hospital, who stepped up and provided the data right away, allowed us as Boulder County Public Health to do some analysis on that data, which informed the efforts that you're seeing happen in the community. I also want to note three specific things that I think are extremely important and really takes the partnership of this community to make this happen. One is the extension of hours by NextCare, Rocky Mountain Urgent Care, and Longmont Clinic to address the needs from 6 to 9 p.m. that otherwise weren't getting addressed in this community. We had people showing up in the emergency department. So I want to thank those organizations. There's lots of thanks. You see there's lots of partners around the table. Also want to thank Salud for sharing their volunteers to help address the pilot project that he's referencing in that packet as well. So in closing, again, I am offering full support as a public health director for this. This will help improve community health in your community. It will help improve economics, and it will help improve quality of life. Thank you.
Thank you, Jeff. Is there anybody else in the audience that would like to come speak? I guess seeing no one, I'll close public invited to be heard.
Mayor, the first item for the study session is a special presentation by Bicycle Longmont. Just prior to that, I believe you have a proclamation on your desk for Bicycle Month that Ryan Kriegerud and members of Bicycle Longmont are here to accept.
All right. Well, I'll go ahead and read the proclamation, and then you could say a few words. And a proclamation designating June 2013 as Bicycle Month in Longmont, Colorado. Whereas the residents of the city of Longmont enjoy a superb quality of life in a livable community, have healthy, active lifestyles, and seek a cleaner environment, affordable transportation, and healthy children. And whereas the City Council of Longmont encourages its residents to be active and healthy, as well as to use clean and diverse transportation choices, and to mutually and courteously share the city's roadways. And whereas Colorado Bike to Work Day on June 26, 2013 provides an opportunity to encourage residents, workers, and visitors to Longmont to bicycle for health, the environment, transportation, and recreation. The month of June is Colorado Bike Month, and June 15th is the annual Goodnight Ride Longmont community-wide celebration of cycling, and whereas the city of Longmont recently has recognized by the League of American Bicyclists for the first time as a silver level bicycle-friendly community because of infrastructure upgrades to on-street and off-street facilities and award-winning bike map, education programs such as safe routes to school, and improved network connectivity. Now, therefore, I, Dennis L. Coombs, Mayor, by virtue of the authority vested in me and the City Council of the City of Longmont, do hereby proclaim June 2013 as Bicycle Month in Longmont. And I invite all citizens in the community to commit to Longmont being a bicycle-friendly community by supporting Colorado Bike Month and Bike to Work Day. And I encourage all residents to enjoy the many benefits of bicycling throughout the year and to consider the City of Longmont as Bike Month during June 2013. So would you like to say a few words?
Well, first I'd like to say thank you very much. This was really a treat. We weren't expecting the proclamation this evening, and on behalf of Bicycle Longmont, our board, our incredible volunteers, and Deborah Kirkoli is here tonight too. She kind of surprised us as well to come out to hear our presentation. It's going to happen in a couple minutes. Just a quick word about what we have going on this month. We have a whole bunch of things going on. The number one thing is the Goodnight Ride coming up on June 15th, which is next week. We're a little white-knuckled on that, but I think it's all going to come together, and it's going to be a fantastic time here in Longmont. So thank you very much for that proclamation.
All right, let's photo op.
One with his camera. 1, 2, 3.
So, Sean. Okay.
Mr. Krieger, if you'd like to start your presentation on Bicycle Longmont regarding the creation of a pedestrian and bicycle safety fund.
Very good. Thank you very much, Mayor Coombs, members of council. I'm excited to be here this evening to talk with you a little bit about a project that we've been working on with city staff to some degree. It's called the Pedestrian and Bicycling Safety Fund is what we've coined it and what we've named it. Essentially what it is, we started working a few months ago on this as an idea that we had after talking with some of our safety officers about how to keep people safer on streets and as well as how to keep people safer during events and so forth. So the kernel started at that point, and it started within me to kind of do some research to find out how other people around the country finance different types of bike education and so forth and bike improvements in their communities. So I started thinking about it, and then I saw a gentleman being pulled over on Ken Pratt Boulevard after seeing him previously cut off a cyclist back at I think it was Boston and Sunset, and then he was obviously speeding someplace and got pulled over, and I thought, okay, sometimes there's karma. But what I thought about was at that moment was, what if there was a way that we could hold cyclists as well as motorists accountable for their actions, and could there be a surcharge put onto moving violations? At that time we were talking about all these different violations that are currently enforced within the police department. If there could be a surcharge put upon on actions that are illegal. And I contacted Advocacy Advance, which is an advocacy organization funded by the League of American Bicyclists as well as the Alliance for Biking and Walking, to talk with them a little bit about what I was thinking. And they said, we like it, nobody's ever done that before, here's a grant for $2,000 to follow up on it. We haven't spent any of that money. All of the stuff that we have been presenting over the last few months has been 100% volunteer driven and so forth. And some of us on the Bicycle Longmont board have really thought more about this surcharge, and we think that overall it's going to be a good idea. We still need to work it out with city staff. So we're here with you tonight to ask if you approve of the concept of the surcharge, and then to direct staff to work with us more earnestly on hammering it out so everyone is cool with the idea. So what we've done in the meantime is we have gone from viewing the surcharge on all violations to just those that are affected by that lead to an accident. So if you saw in the paper, Scott Rochette did a good job at explaining what we're looking at doing. So essentially, it would be a $10 surcharge on tickets that were given out during an accident or that led to an accident. So we're doing a specific thing and then moving forward from there. And so yeah, that's pretty much what a description of that program is. So Sean, if you have anything you'd like to add, or I got a phone call this afternoon from the city attorney, and I was a little bit quaking because I don't know if it's ever a good idea, a good situation when you get a phone call from the city attorney. But I need to point out, I sent out an email to the city council the other night with some more information and some letters, and in that email I wrote that the city attorney's office had reviewed a version of the ordinance and made suggestions to tighten up the relationship between the action and the outcome. And they didn't give us specific items to tighten up. They basically said that there's questions about whether or not there is, this is a fee, a tax, or a true surcharge. Those are three different things, and they deserve more research. And so we're here tonight to say, if we could move forward with option number 2, that would allow us to look at figuring out the legality of those three different things and how they are put into place with this particular item that we're putting before you tonight. So, thank you very much.
All right, I got a couple questions for you, or at least one question. So, in principle, I'm in favor of, adding on a fee for people who cause accidents. I don't have a problem with that. But would it be better to have that money then just go into the general fund and then just have this as being part of a budget that pulls that from the general fund? Because then it's not tightly coupled. I mean, it's just another way of looking at accomplishing the same goal. I mean, I do, thousands of miles of biking, and, I think, one of the big problems with biking isn't necessarily the education of the bikers, but it's the people driving the pickup trucks when you're out on some county roads. They don't realize that they need to give you 3 feet, and even though there's no traffic, they'll buzz by you with 3 inches instead of 3 feet. It's that type of education. But so, I applaud for what you're doing, but, one of my comments is maybe it might be legally easier if it was decoupled as a direct, I don't know. It's just my thought.
If I may,
Sure.
Mayor Coombs, members of council. Sure. Essentially, what we're trying to take a step back. We're very open. Well, we don't want this to be a cars versus cyclists thing. So we want everybody to be held accountable because we're all using the roads, and we should all be held accountable for the rules of the road and so forth. But what we're looking at in terms of how it's structured, whether in the mechanics of it, if it goes into the general fund or it gets held out into its own specific fund. The item that we put together, I basically looked at the surcharge that already exists for the victim advocacy program that's administered through the municipal courts, as well as the surcharge for fuel that allows our police officers to go out and enforce the laws of the land and so forth. And so each of those are held out in their own funds. And then also talking with staff about how they might see this. They said that the general fund is kind of like a big nebulous black hole that once money goes in, it's really hard to get it back to where you want it to go. So it was about an enforceability item. So if we can work with the finance department to figure out a mechanic to put in place that helps to make sure that it goes to where it needs to go, then yeah, we're all for it. So finance is not my gig.
Okay. Councilmember Finley.
Thank you, Mayor Coombs. thank you for your hard work on this. I appreciate it. I do have some questions. I like the idea of a fund, but I'm having trouble associating this particular fee with bicycles. It doesn't seem directly related to me. I would be more in favor of having a fund that was financed through, say, a licensing fee or an additional licensing fee for bicycle safety, rather than having it on moving violations that don't have anything to do with bicycles. That is my first thing. My second thing is funding existing programs. These are already in our packet. These things are already funded, right?
They're not. I think one of those that we listed out in there was a headlight taillight program that the police department offered. That was one that was told to me by another Longmont resident. That's a program that is long gone. It's been gone for quite some time. The police department does have a helmet program that they do, and this might be a way to help fund that one. The one that we really use quite often is the city map, how the city bike map is funded and so forth. That one is directly tied to the budgets within Public Works, or I'm not sure if it's the planning department budget either, but currently the city is completely out of those, and we've been at the farmers market for 3 weeks, and we've had over 400 people come through asking for bike maps and so forth. It's something that we go through all the time. This kind of a fund, and thinking of that as an educational piece, would help us to create a mechanism to keep having more of those available.
Okay. And I'm for all of these existing programs that you've listed here and future programs, with the exception of defraying the costs associated, number 3, because I think paying for the off-duty police officers and the emergency unit for bicycling events kind of opens up a whole bunch of other people who are going to want us to do the same thing. And I think that if you're having an event, you probably need to pay for those things. All these other things sound like wonderful things. I do have a problem with the way you intend to get the money, and although the fund itself, I'm in favor of.
Councilmember Webb.
Thank you, Mayor. This might be a question for Harold or Sean. Do we have anything that do we have certain fees that we currently charge that go directly to specific projects like this? I'm not sure that we do. And it would set a new precedent. One thing that is somewhat similar, I think, is the Art and Public Places funding. And I know that when we were having very hard economic times, people were saying, I cannot believe that we are spending money on art projects at a time like this. But what we do is we lock up those funds so it can only go to these specific things. And so any feedback on that, guys?
Well, we do have the funding that goes to AIPP, but that is actually comes out of the capital improvement projects. We set aside a percentage of that then goes into that fund. So while it's not directly related to this, it is a fund where we allocate dollars in our process and then goes forward. But in terms of something like this, there's not anything that I would say off the top of my head that we have that really mirrors this exactly. It is a little bit different because the fees that we do collect via municipal courts do move back into the system. Those areas where we do have functions, so if I take the public safety improvement fund, that was voter approved. And so those were dollars that were earmarked via a vote that go into public safety. So in terms of something like this, I'm not familiar with it. I'll have to.
Okay. And so I do have, all the goals are laudable. It's the technical details that probably need to be fully vetted. And I would like to see it go through TAB I think they'd have some good feedback on this as well. So anyway, just a couple of thoughts.
If I could add to what the city manager said, the most comparable kind of fund that goes specifically to something that's related to public safety is at the state level. And when you receive a citation for on a state highway or by state police, there is a fine associated with that goes to something related, I believe, to head trauma. And Chief Butler could speak more to that, but that's the closest thing. We don't have anything that we could find in the city budget that is specifically for bicycle safety or other purposes.
Councilmember Levison?
Thank you. So I also look at this as maybe there's a couple of other things that we're trying to do with this, that these ideas that maybe we can use the police and the public safety tax to fund as opposed to starting something new. For example, I know that there's going to be increasing difficulty with keeping the funding for the Safe Routes to School program, and a lot of the bike classes and other safety and educational and helmet program stuff, I think that would fall under maybe funding for that, because it would be new. My understanding of that funding stream is it's new projects and new programs that would be funded by that money. Although we do have a lot of needs to make sure someone is safe on the streets, whether they're in a car or on a bicycle or they're a pedestrian, is also a critical public safety need, in my opinion. So I like a lot of the concepts as well. I just would like to know whether or not we would have what the challenge of this idea is around whether it's a tax or a fee. The other idea that did come through, I think would be a positive thing to explore, is to have that bike registration fee that was very successful in Colorado Springs. I know a lot of bikes are sold, outside the city limits, but I think that people would be willing to have a small fee of $4 to maybe get their bike registered, and then they'll have a benefit as a bike rider to access to programming. So I appreciate all the work you've done and all the different ideas that you brought up, and I imagine this is just a limited list of the ideas, the ones that really floated to the top right away, and I imagine there are a lot of others too. I want to, though, also echo Councilmember Finley's concerns around the using a dedicated fund to support special events involving bicycling, and having run a couple of large public events myself, I would have liked to have kind of support money like that, as you pointed out. So that might be highlighting a greater need in our community for citizen-led public events. And that's a different discussion, but I think that a lot of what you bring up have touched on a lot of issues we've heard too, that are important to the community. So I'll let other people in line weigh in.
Councilmember Samari.
Thank you, Mayor Coombs. Have you guys put together a pro forma of how much money would be required? And have we estimated what the revenues would be from the additional fees that would be put on accidents, to see if it even comes close to meeting your needs?
Mayor Coombs, Member of Council, Councilmember Samori, we have not done a pro forma as such. We did do some investigation as to how many tickets are written, and tried to get the detail of what the value of those tickets were and what a $10 surcharge would do. The current finance software that is currently being used, the police department can track how many tickets they're writing and for what, but in terms of putting a value on that, we weren't successful in doing that because the finance software doesn't allow for that level of detail. So what we did is we basically applied the $10 to the number of tickets that were written, in terms of, I think it's 2,590 was the number that I was given, so it'd be 25,000. And I think with the cost of the programs that Bicycle Longmont already does and the programs that we know that other advocacy organizations do, we think that that would be sufficient and maybe more than sufficient for what it is that we put out there in the council communication.
Okay. And I know you mentioned that you got a grant to do some studies. Have you looked to see if there's any opportunities for larger grants that would provide you with the funds, or have you contacted any of the large corporations in town that may be willing to support such an educational program?
We have not. Basically, most of our time has been spent with getting things ready for the Goodnight Ride, plus this event or this proposal as well. To touch on some of the research that we did, the state of Washington has a surcharge that it puts on violations within school zones to help fund safe routes to school as well as other safety mechanisms. And so we adopted that as well into here. And I think that gets at some of the issues that the city attorney was talking with me about this afternoon in terms of building a stronger relationship between the surcharge, if it is considered a surcharge, to what it is we're trying to accomplish or what behavior we're trying to change. So there is room for improvement within the proposal that you have before you. And so what we're trying to do is acknowledge that we're in a gray area and try to and would like you to vote to have us continue to work with staff to flesh out this concept and bring something more concrete back to you and incorporate all of your comments into that as well.
And I think adding a surcharge to the tickets in a school district makes sense because that relates to safety, because a lot of the kids ride bikes there. Adding them to accidents in other areas that are not related to biking or crossing the streets, can be a little touchy, if you will. Do you know how many tickets are written specifically in school zone areas, and how much revenue would that generate? I know you don't have the answer, but something to look at. And again, look at talking to some of the corporations in town that may be willing to support such an effort as well.
Councilmember Santos.
Thank you, Mayor. Looking at what the other states have done, the two states, they're for moving violations, as Councilmember Smorey said, in school zones. State of Maine, moving violations to fund. Community Policing Institute provides a wide range of programs, including bike safety information for both adults and children. How would the $25,000 be divvied up?
Initially, what we were thinking was, when we were talking, it was a percentage of the fund would go towards concrete projects like infrastructure projects, and then programs, and then the event safety. And what I'm kind of hearing from council tonight is that the event safety piece is probably not going to fly. So we may drop that off.
The event safety thing has me concerned, and when you and I met, that is probably the one thing I think Councilmember Finley said that's the big raising of the flag. Having done events, as Councilmember Levis even said, done events in the city, we had to pay the fee for the park. We paid for the stage. This was a very large national not-for-profit. Mm-hmm. And people were asking me, well, you're on council, why don't you just go ask them to waive the fee? So, one, no, because I'm on council, that'd be stupid. Two, then every non-for-profit, every organization, everyone would be asking us to waive everything. Now, there are some times when we have some discretion depending on whether it's going to be, if Longmont were to get a very large event, then the city can do a very large, its part in a contribution type situation. Get that. That's where I'm having difficulty, is that one, Colorado Springs did new purchases on bike fees for trail systems. Mm-hmm. This is very different than that. Two states did it for these other programs. This is almost implementing a state program at a very local level. Mm-hmm. And then we have the question whether it's a fee or a tax. That looms very large because it seems like a tax. The other members of council bring up very, very good questions. The ride-along with an officer, I've done ride-alongs with PD in the cars. So I think it would be a little bit different with a ride-along with an officer on a bike.
More one-to-one, that's for sure.
Oh, definitely more one-to-one, but that has me concerned. I do like that we do with the helmet program. We're going to be resetting the budget. We're doing some resetting for the 2014 budget, and hopefully we'll be completing the entire reset for 2015. And I've said it before, and I'll say it again, we cannot be everything to everyone.
Mm-hmm.
So I'm not sure about this at this time.
Well,
I kind of like your option 2, support the concept in general. That leaves a lot of latitude for all of us. Provide direction to staff recommending changes to concept, which could be anything. It also gives our attorney, Eugene, a chance to look at it. It leaves the door open, and then direct staff to enable, to approximate the enabling documents for approval. So it keeps the thing moving without killing it at this point. I don't see anything wrong with that option. I mean, we have, our kids now are getting a D on their health report card. So anything we can do as a community to encourage kids to ride their bikes, we ought to be doing that as leaders, I think. And I think, I strongly support option 2 at this point because I don't think there's a downside to it. So if someone wanted to make that motion, okay, I'll make that. That's a motion. I'll make that motion. Okay.
All right.
Councilmember Witt.
Thanks. So the problem we're trying to fix with this is what exactly? What problem are we fixing with this safety fund?
We're trying to make the streets safer for pedestrians, cyclists, and also drivers. Because what we want to do is set up programs that basically tells everybody what the rules of the roads are. We were promoting the idea of increasing safety at events because you have concentrated uses or concentrated numbers of people using the streets at the time. And the ongoing idea is that as a nonprofit, we have to put out a huge amount of money in order to keep our participants safe from traffic and to keep the two uses separate. And that's where that idea came from. And in talking with other events in the area, they said they would gladly locate within Longmont if the safety piece was a cost-neutral item for them. And so we were thinking, that might be a good way to lure in more tourism, more dollars and so forth into our economy that are currently coming to Boulder County Fairgrounds and then leaving right away, or just basically going to Prospect and then leaving right away. Or we could get them downtown or something like that. That was where that idea came from. And because it was a safety item, we put it into this proposal. But it doesn't sound like that's really going to move forward. So we can discuss it, but yeah.
So if that, and it does sound self-serving, that's the only problem. And so if that was one of the main drivers for getting this to be established, if that part is removed, I always think of our Longmont police and Safe Routes to School as the ones that go out and teach. So I will just say that I have some concerns about what we're trying to fix with this, since it seems like we already have the mechanisms in place to address the things that you've talked about. And it just would take a reallocation of focus and funds at the public safety level. And I also want to bring up, we've had a gentleman come in here almost in tears because of traffic tickets and how he cannot afford $160, and $170 would be adding insult to injury. So I want for us to remember the people. It's all well and good when we think the other guy's going to pay it, but when the other guy is struggling to just make ends meet, is it really fair? So just end with that.
Councilman Sackers?
Thank you, Mayor. Mayor, I'm fine with moving this along. I'm uncomfortable with the ride along with an officer because I don't think that part is appropriate. And I'm uncomfortable with the defraying the costs. I do have reservations regarding whether this is a fee or a tax. And
But item 2 allows you to address all those.
it does to an extent. If this does pass, and I think I'm reluctant enough to vote for this to let this go forward because I know the city attorney's office is pretty busy with a couple items in its agenda. But the Transportation Board has not seen this, but. I'm willing to let them have a stab at this and let them vet it out. But 3, as Councilmember Witt says, 3 does sound like very self-serving. As I did mention to you, Ryan, I know Visit Longmont has grants for closing streets. I've directed when the Coloradans have asked for the same things regarding street closures and things. That's where I directed them to when Doug Benny was helping with grants when we had part of the lodger's tax. I directed them to him, and now that Visit Longmont has it, I've directed them. Any groups that want to close the streets, I think you need to go talk to Visit Longmont. They have grants specifically for those type of events those type of funds to do that. So again, those are my reservations. If you're gonna move this along, then again, as Councilmember Samori said, I think moving violations within the school zones probably makes it a little bit better. Yeah, makes it much. Those are the worst. When you see people driving 35 or 40 in a 20-mile-an-hour zone, that's that could be a hefty ticket.
So it sounds like some massaging and horse trading could be in order here. So I've heard a couple of things. I think that maybe some solution and consensus could be built around a parallel process, maybe having TAB and also the Parks and Rec Advisory Board both take a look at this, and then have staff explore this further, and but not right away bring back documents. I'd like to see what happens with TAB and the Parks and Rec Advisory Board, and then see what staff has as far as the legal opinion around fee versus tax, and then get some clarification around if we're going to, for example, look at it for any kind of violation within a school zone, adding an additional $10 or $20 for any violation, including ones that don't result in an accident, because that's really where a lot of education could be done around the interaction of bicycles, pedestrians, cars. That would give us a little bit more of a nexus for a surcharge. So, since the original motion didn't include anything about sending it with a process to the 2 advisory boards, do we want to just vote on the first motion and then we can look at adding a second motion, or do we want to amend and just roll it into one? Okay, so I'll make thank you for the opening. So I'll make a friendly amendment that we add to the motion that we send this to both the Transportation Advisory Board and the Parks and Rec Advisory Board for their review of the information we received, and then amend option 2 to not have staff immediately bring back enabling documents for approval, but to let us take a look at this again at another study session or regular session.
Okay. I guess since I made the motion originally, I'm fine with the amendment of the having TAB taking a look at it. I'm fine with us getting to look at that information before they bring back enabling. I'm not seeing the real strong connection with Parks and Rec involvement. So enlighten me on that.
Well, Mayor, one of the recommended programs was some of the bicycle education programs done through Parks and Rec.
Okay.
And if that was talking about funding, and the helmet program maybe has some relationship, and bicycle registration, those could be activities included in different Parks and Rec activities. So also has to do in general with trails and recreation. So, and also if there's going to be some further discussion about new ordinances and fees, the larger the relevant citizen boards that have a touch on this issue, I think it's great to give them information that we're getting and advice back, because they have different perspectives.
Councilmember Santos?
Thank you, Mario. It might be, and that was my question, why take it to Parks and Rec? It might be that we just send it to Transportation Advisory Board first, and then if staff sees more of the connection that needs to be sent to the other advisory boards, staff also makes it, can make the recommendations to send it to whomever that it needs to, the next advisory board that needs to see it.
All right. I'm fine with that friendly amendment. Are you fine with it? Okay. Then I guess we're ready to vote. Okay, it passes 6-0 with Councilmember Bagley absent. Thank you.
Thank you all very much for your time. And thank everybody out here for your time, too.
Don, you want to introduce the next item?
Mayor, the next item on your agenda is the Longmont Community Health Network, and Chief of Public Safety Mike Butler and Dan Eman, Emergency Manager, will present.
Good evening, Mayor, members of City Council. I'm Mike Butler, Public Safety Chief. Thank you for this opportunity to be able to make this presentation to you. As we move through this presentation tonight, I would like for you to think in terms of the innovation that has taken place in Longmont, and that this is just another innovative effort along the spirit, within the spirit of innovation. About 4 years ago, I took over leadership of the fire department. And during that time, I discovered a few things. One of the first things I discovered was that we have an incredibly talented staff. Our firefighters come with great gifts, great skills, great talents. And along with that, I believe we could offer more than perhaps what we were offering. I'd like to take a minute just to recognize the firefighters behind us and the service that they provide this community. If we could just acknowledge them and the great work that they do. The other thing that I recognized was that their voice was minimized. It was something that they expressed great concern about. The other thing that we discovered was that the fire department is a major medical service provider. We run approximately 6,000 calls a year to medical service calls. The other thing that I realized was that our key strategic partners were basically non-existent or poor at best. Our relationships with those folks that could exist didn't exist. That, frankly, the fire department seemed to be operating in isolation. It was an isolation from the rest of the community, and at some level, an isolation from other city departments within the city. The other thing that we recognized was that there is a heavy reliance on the fire department for primary health care within health services. And the last thing I will talk about, actually one more thing I'll talk about is that medical services in our community are fragmented. The medical service providers, the hospital, the fire department really weren't working that well together. So in that spirit of innovation that our community has come to know, we began to put together some ideas. And that idea culminated in the Longmont Community Medical Network. We also implanted a new leadership philosophy within the fire department. It's a philosophy around encouraging people to have a voice, encouraging people to come forward and to participate in the process. The other thing that we did was I personally went around and met with every single crew approximately 3 to 4 times. I've met with the union. And the other part that I want to talk about is the strategic plan that we put in place. It included many people from the fire department and certainly people from the community. And so before we move forward with any of these strategies, we did hear from a lot of the people within the fire department and a lot of people from the community. So with that, I'm going to turn it over to Dan Eman and have him start his presentation. And then we'll be here to answer any questions. Thank you.
Thank you.
Good evening, Mayor, members of council. I'm Dan Eman. I work for the Public Safety Department. We're going to actually give you 2 presentations for the price of 1 tonight. We're going to do one on the health network, and then we'll do a little break, and then do another short one on some ambulance service issues. So we're going to talk about the community health network first, and this is a really exciting night for me. We've been doing this for over a year now, and it's something I really believe in. I love talking about it. It's something that I've been waiting to get in front of you guys for quite some time. So tonight, you're going to get an update on the Longmont Community Health Network. This has been going on for over a year, and this is a true community effort. This is not something that public safety is driving. This is not something that's my project. This is a community effort. And there are a number of members of the steering committee for the Community Health Network in the audience today. You already heard Jeff Zayak, the Public Health Director. We've also got Rob Spenlow, Deputy Public Safety Chief, of course, Mike Butler. Karen Roney is somewhere back there, I know. Also back here, I saw Beth Lonergan from Mental Health Partners. She's the Chief Clinical Officer for Mental Health. And I saw Nancy Driscoll back there. She's the Chief Nursing Officer for Longmont United Hospital. Chad Arner is the Clinic Manager for Rocky Mountain Urgent Care. And a couple people are traveling and couldn't make it here tonight. Kelly Earhart, who is the Operations Manager for Next Care Clinics, and Jennifer Morse, who is the Vice President of Development for the Salud Family Clinics, couldn't be here because they were traveling. But this really is a community effort, and what we're after is to increase the level and quality of healthcare in our community at a lower cost. And to this point, we have not used any new taxpayer dollars. This project really is a prime example of a public-private partnership and how innovation can benefit our community. We're going to talk about some background both on a federal and local level. We'll give you a little bit more about the origins and the process that we use to identify the gaps and some of the solutions that we came up with, and then we'll wrap it up. So this graph is a picture of the long-term federal debt. The dark blue you see is Social Security. The light blue you see is Medicare, Medicaid, children's health insurance, and the exchange subsidies. Basically, these are all publicly funded healthcare programs, primarily for the sick and elderly. As you can see, the light blue is by far the biggest chunk, and it's getting better. So the problem of our long-term federal debt isn't Social Security, it's healthcare, healthcare, and healthcare. This is a graph of spending. The top black line is the United States. All of the other countries are below that. As you can see, the United States is hitting about $8,000 per capita. That means we spend as a country $8,000 per year per person on health care. And it's about twice as much as every other country in the world. And this is the one that kind of brings it home for us. In the last decade, from 1999 to 2009, the healthcare premiums have risen 4 times the rate of wages. So for every extra dollar somebody's earning over a decade, they're paying $4 more in healthcare premiums. So what that translates into is either businesses are forced to try to come up with a difference, or businesses are forced to drop healthcare. So the result could either be somebody's trying to find a single-payer program, which is very difficult to do, or they're going without health insurance. and it's projected to at least do that in the next decade again. So we spend a lot of money in healthcare. So it would really stand to reason that we get a pretty good deal. We're getting really good quality care. But this is a study that the Commonwealth Fund put together that compared a number of different measurements of healthcare and access to healthcare. The United States is on the far right, and just if you can't see it, anything in red is bad. So green is top two, yellow is middle, red is bad. So as you can see, the United States is at the bottom tier of pretty much every single measurement on healthcare. So that means we're spending an awful lot of money and we're not getting what we're paying for. So this is probably my favorite graph in all of this. And what you see on the vertical axis is the percent of total healthcare spending. What you see on the horizontal axis are population groupings. So if you go to the far right, you see a very little sliver. That's the healthy 50%. Half the people in the country only account for 3% of the costs. And as you move your way to the left, what you see is 1% accounts for 20% of the costs, and 5% of the population accounts for 50% of the costs. The sickest 5% of the people in our country account for 50% of the costs. So a very small number of people place an overwhelming burden on the system. So this is a man named Dr. Jeffrey Brenner. He's a primary care physician in Camden, New Jersey. If you're not familiar with Camden, it's a city about the size of Longmont. It's about 90,000 people. Its demographics are quite different. It's pretty much the first, second, or third poorest city, or first, second, or third most dangerous city in the country. So they're dealing with some incredible issues that we aren't. But this guy is a primary care physician who saw all of these problems and is a very innovative, frankly brilliant guy who's come up with a lot of ways to try to address this, and he's a little more eloquent of a speaker than I am. So it's about a 2-minute video in here. He's speaking at a TEDx event on healthcare in Camden, New Jersey.
And the other part of this that's very important is that Medicare has a fee schedule that's a national fee schedule, more or less. And it, many years ago, made a decision that they were going to set a very high price if you cut, scan, zap, or hospitalize the patient, and a very low price if you talk to them. So the reason that your doctor is running out the door as you're trying to talk to them is because they're paid very little money for talking to you. They're paid a lot more if they can cut, scan, zap, or hospitalize you. This fee schedule is essentially the fee schedule that all fee schedules across the country in which doctors and hospitals are paid is based on fundamentally. So the problem with that fee schedule is that it's driving more and more hospitalization, more procedures, more scanning, and perturbing, if you will, the marketplace of delivery. Not spend $600 million in Camden of public money well. We wasted money. Good doctors and good hospitals all over America go to work every day and deliver disorganized and fragmented healthcare services. Many of you won't know this until one day when you or a loved one are admitted to the hospital and they're lying in the bed and you're sitting next to them, and in and out of the room come one doctor after another doctor, and finally it dawns on you that none of them are talking to one another, that you actually know more about your loved one's care than any of those doctors. And it's because they're each dropping an individual bill. They're delivering fragments of care because they're paid in a fee-for-service model. You know, once again, you know, if you run out of the room or you cut scanners out, you make much more than if you stop and talk to someone. And the problem with that model of healthcare is that it works for the average patient, but as you become an outlier in the system, as you get sicker, the system doesn't work well for you. I made a lot more money if I ran from room to room to room treating head colds than when I walked into the room with a patient. All the greatest moments in my career are the extra 5 minutes I spent in the room. It's the extra moment when I picked up the phone and called someone about their abnormal mammogram, and it's 7:30 at night. It's the extra work that doctors do to coordinate care. All of that is unpaid work, and that's why it doesn't happen. The most expensive patient in Camden was a Medicare patient with $3.5 million in payments. That's one person. 30% of the cost go to 1% of the patients, 80% of the cost to 13% of the patients, and 90% to 20% of the patients. That's true in every bucket I've looked at. This is true for union patients, commercially insured patients, older patients, younger patients. A small sliver of people that are sick are being ignored in healthcare because the doctors are running from room to room to room, not paying attention to them. 10,000 people every day turn 65. We have 85 million baby boomers headed like a freight train down the tracks to our delivery system. No idea how to reduce costs. We pay twice as much as every other country. We have a cataclysmic problem, and we have made the world's largest economic bubble, far larger than the housing industry. Healthcare is 18% of our economy. It will become 25% of our economy. So we have a bubble of hospital beds, of cardiologists, of orthopedists, of capacity within the delivery system, that if you ever right-size the delivery system, you probably would need all that capacity.
So locally, this is a graph of uninsured. So the highlighted yellow at the bottom is our city. Yeah.
Could I just ask, did that gentleman ever address the new healthcare law and how that would influence the status quo?
Yeah, he does. He actually talks pretty extensively about it. And the steering committee got a presentation from a woman named Dawn Joyce, who used to work for Boulder County Housing and Human Services, and she's moved on to the state to help them implement the Affordable Care Act. So it's something that we've talked about in this. Mostly what we'll see locally, hopefully, is an increased number of people that are going to become insured. But the problem there is we're going to hand out an awful lot of little Medicaid cards and may not necessarily have the capacity to handle it. So there's kind of a give and take there. We're thinking that about 57% of the population of these uninsured, these 17,000, will become insured through Medicaid expansion or the individual mandate. So we think there will be some effects, but the problem when the Affordable Care Act really gets rolling is, can we handle the insured as they come down the tracks?
One quick question, Dan, about this chart up here. I noticed that Pueblo actually decreased by 7%. What did they do in that town to decrease the number of uninsured by 7%?
I can't answer that. I don't know.
Okay.
But what you did notice in this is that Longmont is the second highest percentage. We're at 19.4. The only community higher is Aurora. We're also one of the few communities that number's increasing. So there's 17,000 people in our community that are uninsured. And then the chief talked about the strategic plan. This is something that took a couple years, so we ended in 2010. Steering committee of 25 people. It ended in a 2-day retreat. And we identified a list of strategies, a few of which really fueled the formation of this group. They were kind of the genesis of this whole thing. So there's a couple of them listed there. So how are we going to move forward? That's the next thing we talked about. We understand the problem, but we get it. We can't sustain this healthcare system. It's too expensive. The care's not as good as it can be. At some point, something's going to happen. We can't wait for federal state legislation. That clearly isn't working for us. We have to create a local healthcare solution. We have to do something that's going to work for our community. So as our role in government, we saw it as a convener role. What can we do to get everybody together, the experts, and start talking about what are the gaps? What are the partnerships? How can we engage our community more meaningfully to increase the level of partnership and fill the gaps? So in February of last year, the first meeting of the Longmont Community Medical Services Network was convened. We've since renamed it to the Longmont Community Health Network, but these are the people we invited. We sat down and we thought of everybody we could think of that was related to medical services at the time. We've added, we've subtracted, we've kind of evolved as we've gone, but as you can see, the partners are there. Everybody we could think of. You heard from Jeff Zayak. The community response to this was incredible. But one of the things we saw at those first couple of meetings is there was a lot of introductions being made, which surprised us a little bit. There was a lot of people in the medical community that didn't know each other. We started this process we presented them with 3 big overarching goals, a proactive, a reactive, and outreach goal. And we embarked upon this 5-month strengths, weaknesses, opportunities, and threats experience. And we kind of asked every agency there, what do you think are your strengths? What are your weaknesses? We did it as a group, and the gaps became evident. They were obvious. Everybody pretty much knew them going in. So we identified some task forces to bring together the subject matter experts to really go to work on what these problems are. So the vision, we want to use our role as a governmental entity to bring people together. We want this to be a public-private partnership. We want to facilitate partnerships to fill gaps. We want to increase partnerships that are already there. We want to utilize existing services as much as possible. We don't have a competitive dog in this race. We're not in this for profit. What we want to try to do is see what we can do to bring people together and identify gaps. We want to see if there's a way we can capitalize on these overall system savings to fund these things in the long term. As we start to bend this cost curve a little bit, I think that there's enough savings in there that we can fund the ongoing efforts, but we need to do some things to prove that or not. And one of the overall statements we really go by is the right service by the right provider at the right time. And a lot of that's about efficiency and making sure access is there. So let's talk about some solutions. Solution number one, reduce the number of non-urgent cases seen in the Longmont United Emergency Department. So we have some national studies that show that somewhere around a third of all emergency department visits are avoidable. Basically things that a primary care physician can see. Now, that number is a little misleading because that's assuming that there is a place for these people to go. Now, at some point at night, the only option is the emergency room, whether you like it or not. So this number is making an assumption that there's always access. So in our community, we don't really know what it is, but certainly there are some. There are a lot of people that go to the emergency room that don't need to go there. The cost of care in the emergency department is much higher than it is in an urgent care or primary care setting, and I think that's kind of obvious. The emergency department is a Cadillac. They've got everything. They have every test, everything you can imagine. And one of the things that the data that Jeff Zayak kind of alluded to told us is 25% of the visits to the LUH emergency department occur in a 3-hour time period, 6 and 9 p.m. So when people get off work, there's no primary care facility available to them, so they go to the emergency room. As a number you can wrap your heads around, there's about 30 to 35,000 visits to the emergency room every year. So that's a lot of visits. Another study told us 52% of the Boulder County residents that went to the ER in 2011 felt they could be treated by a primary care physician. But the primary reason those 52% went to the ER instead is because there was no primary care physician for them to go to. They were in that 6 to 9 gap. So clearly, that's a gap. So to start working on this, we have an alternate destinations task force. Those are the people on it. A lot of public safety representation, the administrator from the Longmont Clinic, some members of NextCare, Chad from Rocky Mountain, Laura Boscia from Kaiser, and Deb Hopgood from AMR, who I believe is also here. So this is kind of our purpose statement, but really what we want to do is find places we can take non-urgent cases that aren't the emergency room. Boiling it all down, that's what it is. Regardless of insurance status, can we address the uninsured, the underinsured, and find a place that we can get an appropriate level of treatment that isn't the emergency room? So when we start this, how are we going to know if we're successful? I mean, I think the top two are fairly obvious. In the context of 911 calls, if we start diverting patients, we're starting to find success. And then we need to figure out if we have enough alternate destination sites. Is the supply and demand going to match up? Are we going to be effective with this? The third one, the public and private insurance companies reimbursing ambulance services. So right now there's one option. Insurance companies will reimburse a trip to the emergency room. That's it. So it's incumbent upon us to start these discussions with not only the public insurance companies, but the private insurance companies to see if there's something we can do. Is there a business plan we can present them to say, look, this makes sense. Can we reimburse this? In the long term, what we'd really like to see is trends of people not calling 911 in the first place. Is if our community is self-sufficient and self-aware to understand, I don't need to call 911 to take the expensive ride to the expensive place when I can find a way to go to my primary care physician or an urgent care. We would love to get there. System cost decrease for non-urgent care, we'd like to see 10%. What have we done so far? We've identified the sites. So we have a pretty nicely geographically spaced core 3. We've got NextCare, Longmont Clinic, and Rocky Mountain Urgent Care. And for those that don't know a lot about NextCare and Rocky Mountain, they are urgent cares, but they also have primary care capability. So they do serve as primary care providers. Longmont Clinic has an urgent care setting, and they're the largest of the primary care providers. They've got the most doctors in their building. We talked about the initial list of non-urgent call types. So what are we going to start with to start diverting these patients? And these are very simple things. These are things that that our medical director and all of the clinics feel are appropriate. There's not an issue with whether or not they can handle them. These are simple things, you know, sprains, simple fractures, small cuts, upper respiratory infections. All these are really in the wheelhouse of primary care. How many of these there are, we're not really sure yet. We're going to have to kind of start to find out. We figured out the logistics. We talked about that 6 to 9 gap. We're starting a triage assessment process. Without changing the system as it exists now, we're trying to figure out what additional training our paramedics need. You know, it's a little different for them to determine whether or not a patient is going to go to a urgent care or a hospital. They're not used to that setting, so we're trying to figure out what kind of training do we need to provide to them. We're going to eventually get to this menu approach is the goal, and have our paramedics be empowered in the field to make a lot of different determinations. Everything from, we're not going to do anything for you today, treat right there, take you to an urgent care or a primary care facility, or of course the full-blown, yeah, we're going to the hospital, this is a problem. That's the goal. We're going to try to empower our paramedics to make those decisions in the field. We'd like to eventually move to alternate modes. We'd like to skip sending the expensive ambulance if we don't need it. Is there a different mode of transportation we can use, whether it's you know, a VIA bus, a wheelchair van, you know, a private provider in a Subaru, whatever the case may be. We'd like to investigate that too. And then talked about the payers. We need to engage them with a business plan. We've started this process. We've talked to the Colorado Medicaid office. We've talked to the medical executive for Cigna, who just happened to have been a primary care guy in Longmont for about 20 years, so it was a nice connection. What are our partners contributing to this? The clinics, like Jeff Zayak mentioned, they have stepped up incredibly. They've all agreed to start seeing these patients regardless of insurance status. The determination we want to make in the field is medically based, not insurance based. So they've all agreed that if it's the closest clinic, they're going to get the patient. We're not going to worry about do you have insurance or not. They've also agreed to extend their hours to 9 p.m. once we start this, to try to adequately fill that 6 to 9 gap. And further, 2 of the clinics have agreed to take on additional Medicaid patients. So that goes back a little bit to issuing all those new Medicaid cards. But that's going to be a problem. We need to connect people with a medical home, a primary care provider. And these clinics are stepping up, saying absolutely we can take this. Salute Clinic already does the vast majority of these, but Salute and Kaiser would like to see their own patients. They're kind of working on what else they want to do. But I want to mention in this what incredible experience it is to work with these clinics. These are competitor clinics, and they're sitting around the table asking questions like, what's best for the patient? Yeah, we can take some of those. They know they're going to take a loss on these uninsured patients. But that's not the issue. The issue isn't we don't want to. They're stepping up and solving the problem. What can we do? What else can we do to help the community? It's frankly been inspiring, and these are wonderful meetings to attend. These are clinics that are in it for our community. So the second thing we're looking at under this particular solution is community health portals in strategic locations throughout the city. These are also kind of a fire station clinic idea. And we stole this idea from Alameda County, California, who started this with their public health department and the fire department. And they're locating, in their case, pretty much full-blown clinics and fire stations. I don't know that we're going to go to that level, but for us, this is an access issue. This is something about, can we provide access into the healthcare system? Uninsured patients. Can we provide preventive care? Can we provide services to get them into the healthcare system with insurance? Try to increase the level of access for uninsured and underinsured people. Can we use these as limited mental health crisis counseling areas? There's any number of things we can do with this. This is really a future strategy for us. It's clearly going to require a little bit of funding or a really increased level of partnership, but it's something that we think has a lot of promise. As we look way down the road, these community health portals could really evolve into full-service clinics if that's a gap. If that's something that we need, if there really is this overwhelming supply of Medicare clients, how do we fill that gap? We may look at this. Is this something we could start providing services to city employees? Is there an increased level of healthcare services we can do for our employees to keep them at work? Wellness, preventive care, hubs for chronic disease management. Can we do diabetic education services, congestive heart failure services? There's any number of things we can do with these health portals and these fire station clinics. So solution number 2, create a patient-centered in-home intensive care coordination system. This is about that 5%, 50%. This is about the small percentage of people that are really, really sick that cost a lot of money. So you heard Dr. Brenner talk about that fee-for-service model that really makes care fragmented. Doctors are not incentivized to coordinate care. These are the cases that are social in nature more than anything else. They require a lot of wraparound services, and they're almost guaranteed to have mental health and substance abuse issues. So there's a couple of things we're looking at here. One is Steal the Camden Coalition model, and the other is some community paramedicine stuff. This group of people are the experts in our community in care coordination. We have the manager from the hospital. We have the director from Salud. We have the director of the local version of Mental Health Partners, our ambulance providers here. The director of the ARC is on this. And I love going to these meetings because these are truly engaged, community, inspirational people. I look forward to these meetings for a long, long time, and I always leave them with just being inspired in what these people can do for our community. We've stolen models, and I say that unabashedly. We have stolen the Camden Coalition model that Dr. Brenner created. We're looking at some other evidence-based stuff from Mary Naylor, who's kind of the pioneer of this. Eric Coleman, who's a local doctor from CU Denver, who got a bazillion-dollar Genius Award for this exact work. And the transition of care model is existing in our community with Salud and Longmont United. It's a model they're using now with health core workers that visit patients in their home, and it's been very successful, and we are absolutely stealing that too. So we have some goals here. Some of this stuff is about immediate and intensive follow-up. This is being in patients' homes. This is getting there within 24 hours of discharge. This is working with them to build a care plan. What specialists are you seeing? Show me all your medications. Has this guy ever talked to this guy? What services are you taking advantage of now? Do you have a primary care provider? A really intensive in-home assessment takes place. And then connecting that patient to primary care as soon as possible. That's the end goal in this, is to connect this patient meaningfully to a primary care provider. Connect the patient with existing wraparound services. Like I mentioned, these patients need social help almost more than medical help in a lot of cases. Can we connect them to Meals on Wheels, home health care, transportation services, all of the existing services in our community that they may not know about? Help them make those connections. Start to work through all of those barriers that these kinds of patients have. Focus on the 5%. Focus on the uninsured. This is something that's going to affect a relatively small number of people in our community, but the effects are going to be enormous. And then the bottom part is probably the most important. There's an equal emphasis in this on coaching social skills. A lot of these people have difficulty with day-to-day things. You can help them read bus schedules, balance their checkbook, all of those small barriers that just get in the way for them to access care when they should. And the bottom quote is a really smart guy from Harvard that basically said, nobody's responsible for this stuff. There's nobody whose job it is to do this, really. There's nobody who's incentivized to do this. There are pockets in our community that do this, but not on a grand scale. This is kind of a difficult concept, so there's a couple of examples in here from the Camden model of the kinds of patients that are targeted under this. These are real patients. 55-year-old guy admitted to the hospital for a GI bleed and shortness of breath. He's a Medicare, Medicaid, he's a dual eligible. Those are by far the most expensive patients in the healthcare system. Lives alone, takes 12 medications, and 6 months prior to enrollment in their system, 9 ED visits and 6 inpatient stays. Has a laundry list of chronic conditions. I mean, I don't even know what some of those are. But this guy is dealing with a lot of stuff on a daily basis, and these are the kind of patients that need our help. These are the kind of patients that don't get served by the current healthcare system. This is the graph they put together, and the pink lines there are inpatient admissions, and the longer the line is, the longer he stayed. The little blue lines are ER admissions. So this guy in 6 months cost the healthcare system $300,000. After they enrolled him in the system, he's cost the system $0. Now, clearly that's a home run. Not all of these are going to be home runs, but this is the kind of dollars we're talking about, and these patients exist here. Another example, 62-year-old guy, has some diabetic issues. He's homeless. Again, he's kind of a double coverage guy. Has a lot of chronic conditions, diabetes, kidney disease, substance abuse, has some mental health issues. These patients exist in our community. 1 year prior, 10 inpatient stays, 3 ED visits, cost the system $100,000. After a year, They knocked it down to 4 ED visits and 1 inpatient stay. So some of this is incremental. You know, if you can take the $1 million patient and turn him into a $700,000 patient, that's still an enormous amount of savings. Does it work? Well, the Top Tier Evidence Initiative is kind of a place that validates studies. They kind of go through and say, that's a good study, that's not. And they've validated a lot of these transitional care model research that show a 30 to 50% reduction in rehospitalization, a 40 to 50% reduction in ED visits, and an overall saving of $4,000 a patient. That's pretty significant. I mean, we're talking about 30 to 50 and 40 to 50. These savings are enormous. And the thing that these studies don't take into account is all of the other services. This is just hospital stuff. It doesn't take into account the ambulance charges, the charges for our public safety responders, the public health charges, are they going to the ARC, clinic savings, all those kinds of things add to that $4,000. Our goal is to transition patients to their medical home in 60 to 90 days. What we want to try to do is that brief, intensive intervention to try to remove all those barriers and transition them with a better relationship to primary care. That's the end goal of a lot of these things. If we're successful in intervening in just a few of these, there's enough savings that it's really going to start to bend that cost curve downward. It's going to start to reduce the overall system's costs and drive down the overall cost of care, which is good for everybody. If we can prove that, and it's consistent over time, we can try to look at ways of reinvesting that savings. Are we saving specific people in the network a certain amount of dollars that we can ask back? Hey, we just saved you $10, can we have $5? And have those conversations if we can prove savings over time. We have a pilot that we're just about to start. Stealing the Camden Coalition, I've kind of burned up the phone lines to those guys. They're incredibly receptive. They've given us every form, every flow chart, everything. We went through and modified them a little bit for our community, but not much. So for our pilot, the care coordination team in the Longmont United Hospital is going to pick 3 or 4 people that fit our model. They're going to enroll them in the hospital, which is what we would typically do, enroll them right there. Go through, this is the program, is it something you're interested in, get them to sign all the releases that we'll need, and then we'll have a team visit that patient in their home in 48 hours. Visit them a couple times in a week. A nurse on that team will go with the patient to their primary care provider with list of discharge instructions. Here's our medications. Did you know he actually saw this specialist and they provided this, and try to see what works for that patient. What are your goals? What can we do for you? And then after that first week, there's a switch. There's a switch really to the social aspect. The social worker really starts to take the lead here and embrace those wraparound services. Do you need Meals on Wheels services? All those kinds of things. And then we stole a model called the 4 C's model from Boulder. I can't remember what the C's are, but I think it's something like complex, client, care, collaborative. Basically, it's a group of all of the social agencies, and they get together and do case reviews. So we're stealing that model, and the social worker on the team will be kind of responsible for pulling all those people together. Hey, have you seen this person? What are you doing for them? Hey, we saw them last week. Hey, we saw them this week, and start to defragment that level of care. The task force will oversee it. We'll make alterations as we need to, and do all kinds of data gathering. The second piece of this care coordination system we're talking about is community paramedicine. And this is really about preventive care and the lower acuity cases. Those complex cases will be handled by those in-home teams, those 5%. What community paramedicine really is it's using our paramedics to fill gaps in the healthcare system. It's existing resources. What can we do to utilize the talents and skills of our paramedics in new ways? Try to make them more valuable to the community, have them embrace the proactive services more. This is about prevention and continuity of care, really to get those small programs intervene to prevent them from being large problems. Can we find a way to get that person who's been newly diagnosed with diabetes, the way to effectively check their blood sugar, get them on a diet plan, all of those things that if we can't have that brief intervention early on, start to snowball, and then they turn into one of those 5% cases. That's what we're trying to do here. Utilize our paramedics as a cost-effective solution, and then marry them up with care coordination teams on the lower acuity kinds of cases. These are some examples of what we'd like to ask them to do. Health assessments, chronic disease monitoring, medication reconciliations, discharge follow-ups. So an example of a discharge follow-up would be, say we have a lower income member of our community who goes to the Salute Clinic, has a minor cut or some kind of issue that's going to require a follow-up. Usually what Salute will do now is say, hey, come back in 2 days. That's really the only option. But if this person has a job where they can't take off, they can't get childcare, they're not going to go back. So can we provide a discharge follow-up in that case? How cool would it be if we have one of our paramedics going to that person's home or work with their iPad, take a little picture and say, here's what the cut looks like, Doc, what do you think? Brief intervention. Won't take a lot of time. If it's something that's serious, hey, we have a paramedic there. They can treat them. They can take them to the hospital. It's that brief intervention that's going to prevent the long-term problem. Connect them to social services. And we asked the primary care providers. We asked the providers at Salud. We asked some of the other primary care guys, if we had this resource available to you, what would you want? Check in on high-risk patients and miss appointments. This is something that's a big gap for them. Maybe they have a really high-risk person that just doesn't show up. They don't know what happened. If we can have, as part of our daily routine, have one of our paramedics check in on them. Did you forget, what happened? Just make sure everything's okay. Basic medical assessments. Can you check this person's blood pressure? Check their blood sugar. In-home assessments. Discharge follow-ups, like I mentioned before. There's not a lot of this going on. The definition of community paramedicine is extremely wide. It varies a lot from place to place. But as is kind of our MO here, we stole something here also. There is a private ambulance provider in Texas called MedStar, and they have a community health program they've been running for a couple years. They targeted 43 patients, and they found an average savings in their program of $55,000 a patient. So what's different about that number is they added in all of those other things that the other studies didn't, ambulance charges, all those things.
I have a quick question. Does our ambulance AMR have anything similar to that?
They do in other areas. We don't have anything like that locally right now.
But they do have it. Thank you.
So how are we going to measure success here? A reduction in system charges for the patients enrolled. The studies are telling us maybe it's 30 to 50%. We don't know what it's going to be in our community, so we're going to aim for 20. Reduction in ED visits again. An increased level of patient satisfaction. Really what people have found is patients don't like disjointed care. They don't like feeling like they're fragmented. They like the fact that somebody's there to help them overcome those barriers. Patients are happier in this program. And then a lot of system metric stuff. How many times do we visit them at home? All those kinds of things. So we have a pilot here too. We're partnering with Salud, who's been an incredible partner in this process. They've just been absolutely amazing. They've never once said no. And I've tested them. We're going to partner with them and their care coordination teams and their medical director to supplement their transitions of care program. So that's the program they have with the hospital already, where they have some AmeriCorps workers visit people in the hospital after they've been discharged. But what they'll tell you is one of the weaknesses they have is they don't have any level of medical training. They're good at the social stuff. They're good at connecting to the social services. But if we can put a paramedic on top of this, it's going to increase the capacity to really be able to do medication reconciliations, blood pressure checks, all those kinds of things. So we're going to try that there. We're going to do it out of Salud to start with. The task force, again, will oversee the process and just see how that goes. Technical difficulties. Okay, well, I'll work on that in a minute here. The third solution to this is about outreach and education. So, give me a second here. Excellent. Does your finger work better than mine?
No. This might be.
Aha. You were the magic. We're just going to bring her everywhere we go. It'll be fixed. So solution number 3, encourage and promote patient self-sufficiency. This is really about outreach and education. We have a task force dedicated to that too. This is really made up of a lot of community services people, some public safety outreach people. There's some key words we talk about there. A lot: self-sufficiency, access, education, changing expectations. And these are a few of the different strategies this task force is working on. Equitable access to health and medical information, especially things that are culturally appropriate. Can we educate our community to understand really everything that's out there? Because they don't. I think what we're finding is there's an enormous amount of services that we're not able to connect people to. Can we provide information that will allow people to connect on their own? Educate and support our community to utilize the appropriate level of medical services. So the tactic here is a lot about informal navigators. Are there experts in our community? Are there trusted members of our community that we can start to provide training to, information to? You don't need to go to the ER for that. Can you go to this clinic over here? That sort of thing. Start to feed our community proper information around the proper usage. You know, we'll find a lot that people don't necessarily understand how to work the healthcare system, and frankly, it's enormous. Who does? But can we start to target the informal experts in our community with a little more education that they can start to help us with delivering proper information? And then the different set of expectations and behavior patterns around target groups. Is there a way that we can target specific pockets of our community, whether it's through data hotspotting or surveys or whatever the case may be, to really deliver a targeted message to a targeted part of our community, to start changing the behavior on a really small part of our community rather than kind of the big community messaging campaigns that don't necessarily have the biggest impact. Now, in the long run, this may be where we make the most gains in our community. If we can get our community to start self-selecting and doing things appropriately without intervention, that's going to be an enormous gain. So to start wrapping it up here, for over a year, we've been talking to the experts in our community. This is a community effort. These are the health and medical providers here. We've identified gaps. We talked about the 5%, 50%. We talked about the 17,000. We talked about the inefficient use of public resources, the usage of ED as the primary care provider, the fragmentation. These are all gaps we're addressing. So we're trying to reinforce existing services. We're trying to see what's there. What can we do to supplement that? Can we supplement that transitions of care program with a paramedic? Are there things we can do with existing resources to start creating new partnerships? And we really feel we can create the model local healthcare system. We can create something here that is the model for everybody else to look at. We're a perfect sized community. We're not too big, we're not too small, we don't have competing hospitals. We have health and medical providers in our community that are engaged. I mean, you can see that, you can feel it in this process. This system is going to be flexible, it's got to be adaptable, it's got to be partnership driven, we have to be ready for failure, we have to be ready for incremental success, and this is something that whatever changes the Affordable Care Act brings, if we have the system in place, we can respond to those immediately. So far, we haven't required any new taxpayer dollars. All of our pilot programs are utilizing existing services, and we're going to try to validate the effectiveness of all this stuff with things that are already in place. In the future, if we can start to meaningfully bend that cost curve and prove savings to people, there are enough savings in the system to do everything we want to do. It's just a matter of whether or not we can create a mechanism to get them. Community benefits. How is our community going to benefit from all this? One of the main things is, I keep kind of saying bending the cost curve, and that's really about driving the cost of care down to where it's going to start to meet the expenses and creating that gap in the middle. And we're doing that through this complex case management, addressing that expensive 5%. If we can fix a small percentage of those, the savings are enormous. Reduce the usage of our emergency department as a primary care provider. Implement that community paramedicine program on the front end. So care coordination is all about the back end. It's all about getting people after they've been in the emergency room. The community paramedicine is all about the front end. What can we do to prevent them from going there in the first place? Increase connectivity to primary care through outreach and care coordination. Focus on the uninsured and underinsured members of our community. That's a lot about community paramedicine, health portals. How can we create access points for the uninsured? There's no options right now if you're uninsured. You go to the emergency room. That doesn't make a lot of sense. Now you're using the ED as your primary care provider. What can we do to create an access point for uninsured? What can we do to provide preventive care services, education services, disease management to prevent those uninsured from becoming the really, really expensive uninsured? And one of the things I didn't talk about a lot, but is a substantial problem in this whole thing, is mental health and substance abuse. That's kind of one of the problems we don't necessarily look at a lot in our society, but it's all about that 5%. You look at almost all of those really complex cases, and it's mental health and substance abuse. Whether it's at the core or as a result of, it's there. And then finally, the community benefits just by being healthier. That benefits everybody. Healthier workers are more efficient. Healthier kids learn better in school. A healthier community member is more engaged. They're more part of their surroundings. They're not sitting in their home. They know how to access care. They know how to be appropriate. They know how to advocate for themselves. They know how to access all the services that are available. And that's the end goal. We want a healthier community. And with that, I'll finish up this part and take any questions that you might have.
Well, first of all, I want to just add that I thought that was an excellent presentation of a very complex issue that a lot of people must have worked really, really hard on for our whole community, and I'm proud of this community to undertake something like that. And you did a great job of presenting a very complex issue tonight, so my hat's off to you, Dan.
Thank you, Mayor.
Councilmember Santos.
Thank you, Mayor. Thank you, Dan, for not reading the slides. So we have presentations where people just read the slides. Thank you for not doing that. The one big question I have, we're going to be implementing this for residents of Longmont, correct? How are we going to do that?
Well, we're going to be implementing this for anybody who accesses care in Longmont. So there's a lot of people who aren't residents of Longmont that go to the emergency room. There's a lot of people that we transport with ambulances that aren't members of our community. So it's targeted at people that access care here. Now, it stands to reason that those complex 5% are, they're here.
Okay, because I just thought of, we had a discussion here a couple of weeks ago regarding homelessness. And other cities are, while they're cutting their budgets, we're finding out, in fact, I just read a report that in Boulder, where Boulder's finding out that a lot of people that they're helping with their services aren't even from Boulder anymore. They're coming in from other municipalities. And I think if we were to do something of the same survey, we'd find some of the same statistics. My concern is for the residents of the 16,000 residents that are uninsured for the city of Longmont. Taking care of the residents, if we're going to continue to do this, the residents of Longmont. Not taking care of the rest of the state of Colorado. That is my concern. And of course, then expanding on that is that, I know the chief and I've had a conversation about what is the role of municipal government? Can we help? And it looks like we are helping, and I'm glad that we are being a facilitator and working with the partners. But when you started talking about a healthier community, it dawned on me. Are we going to have people coming into other municipalities, going into a residence, to someone's residence, then calling and then saying, well, I have my cousins here from another city?
Mayor Pro Tem Santos, thank you for the question. We did have that discussion. I think the question that really is on the table is, if we don't do this, what do we end up with? We'll end up with what we have now, and that is a fragmented medical services system in this community. What we can't do, great question, we can't necessarily predict what that will draw into our community. But we sincerely believe that this Longmont Medical Health Network will benefit our community in a big way. Will other people want to take advantage of it? Of course, potentially. But I think the real question is if we don't do anything like this, what will we end up with in terms of our medical services community? As Dan indicated, things were fragmented. People didn't talk to each other. There was tremendous duplication. A lot of things falling through the cracks. A lot of money being spent that no one knew about over and over again. And so what we believe is a more seamless approach to medical services in this arena will really help us reduce costs, minimize that duplication, and bring about what we think is a better health care. Sure. In terms of the role of government, we believe actually that this is actually a primary role of government. This is not necessarily a service that the city of Longmont is exclusively performing. We've become the convener of a group of medical service providers, the clinics, Boulder County Health, the hospital, fire department, AMR, community services, that are pulling all of this together. We could have a discussion, a philosophical discussion about the role of government, but being a convener, being a facilitator, being a galvanizer, and being a high leverage point for bringing lots of services together makes a lot of sense in terms of what the role of government can be, as long as it doesn't have to be the point, as long as it doesn't have to be the deliverer of those services. Now, we are, in fact, delivering some of these services, as Dan talked about, through community paramedicine and potential for clinics in our stations. But that's something that we believe that we already have the resources for, and could pull that off in terms of without adding any more to the budget.
Sure, and I'm fine with being the facilitator and helping the best way we can, as long as it doesn't diminish the services that we provide to the residents of Longmont. That's my concern. Whether it's the fire protection services that the men and women behind you provide to the residents of Longmont, the ambulatory services that we get, that they most of them are EMTs or paramedics, provide to the residents of Longmont. As long as that does not diminish, I don't have a problem with continuing along this path, as long as those things don't diminish. Once that I start, for me, if things start to deteriorate, then I'll start to have more and more questions and concerns. But when you were right near the end, I just wrote down, how are we going to implement this for the residents of Longmont only? Because once we start down this path, word gets out, Longmont's providing this, and then I'm not saying we're going to open the floodgates for everyone to come to Longmont for medical services. It's just another thought, and apparently you guys have addressed it. Maybe.
Councilmember Finley.
Let me just add one more comment. We are quite aware of the core services that we're currently providing, Mayor Pro Tem Santos, and we do not want to diminish those as well. We believe we have the capacity to do considerably more in our community than what we're doing, given the level of work and certainly the level of skill and talents that our organization has. We believe there is an unmet need in our community, and that we have resources right now that we can marry to that unmet need without question. But we will always keep in mind our current core services, but we also believe we can add more core services that can be of great value to our community.
Councilmember Finley.
Thank you, Mayor Coombs. We've been talking about this for a long time, and I think a lot of it has a lot of merit. And the role that I see us playing in this kind of concept is the role of coordinator. What you've already done in coordinating, making people talk to each other who hadn't talked to each other before. I think that is our role. I think our role is to provide that that level of making sure people talk to each other, and making sure, especially those 5% who make up most of the cost, making sure those people are taken care of is very important. And I'm really glad that you used Dr. Mark Latos, because he's an excellent resource for this. He's been on every side of this issue that there is. So I think you picked a great resource there to talk to. The only thing that bothers me a little bit is to see us do things that private companies can already do. I have a philosophical problem with that. It says right in your report that we're very happy with the service we get from AMR. They can do some of this stuff in addition to what they're already doing, and I would really like to continue that. that relationship, because that works for us and it doesn't add to our overhead. And I don't, as much as I want us to see us coordinate and take care of people who aren't being taken care of, I don't want to see us in the healthcare business. So that's my only concern that I have.
Councilmember, well, maybe I should follow up because I have a comment that kind of relates to what Bonnie just said. I think if we have extra resources that aren't 100% utilized, you've got extra capacity, I don't have any qualms of using those, taking a resource that might only be used at 85% capacity and taking it to 100% capacity. I think it would be foolish as a government not to do that, even if it is a public resource versus a private. So that's my only comment to Bonnie's thinking. So, Councilmember Levison.
If I could just address Councilperson Finley's comments. Yeah, AMR is capable of doing this. I'm not sure, Dan indicated that they're pulling it off somewhere else. I'm not 100% certain where that's happening. I know there's some struggling going on with that, but what we're not certain of is if AMR may not charge an additional fee for that service and for our community. And this model is not charging a fee. And so that's just something else to keep in mind. Thank you.
Councilmember Levison.
So I want to relate a very compelling situation that occurred that was recounted to me in the days that I was a neighborhood group leader in historic East Side neighborhood that would absolutely be a case for this system. One of our neighborhood volunteers was walking around with the neighborhood newsletter, knocked on a door. It had been a regular route this block for years for this person. And she sort of knew the people there. It was a summer's evening, and the screen door was open. And the people called her in because they couldn't get up to answer the door. It's an elderly couple, one of them on oxygen. Another one that also had huge health issues. And they tried to engage her in some ways about, what they could do to get access to some things without coming out directly. They were proud people, but the house was sweltering, no air conditioning, one small fan. And I got a phone call and said, what can we do? And when I started calling the police department, there could be a health and safety check call made if there would be a community member that would express that level of concern. But this couple was in such urgent need of these kind of coordinated wraparound services. And later on, we did find out that each of the two that lived there in the main house had been in and out of the hospital. They were obviously not getting all the services. They had another family member who lived in an accessory dwelling unit on the property who also had some health challenges that they were not coping with and could not provide additional support to those family members. And the real tragedy was that eventually there were numerous ambulance calls to the home. And eventually, one member of the couple died, and then shortly after the other one did. And so you wonder if this situation, if this health coordinated care network was in place, could there have been longstanding members of our community that would be served better? That we always look to the health and safety of folks in the police department is willing to go out there and visit people, but really what was needed in that case from several years ago is exactly what you're presenting to us. And these folks had been living in Longmont, 40, 50 years they'd been in this house and owned that property, and yet we were failing them altogether. And had that neighborhood volunteer not be walking around that newsletter, they wouldn't even gotten the one check they got. So in tribute to that nameless couple and the other family member who lived on the property who eventually got some services after they passed, you know, it saddens me that their quality of life had deteriorated so much, and there was very little that we had of this coordinated network of services that they could have tapped into. And just that quality of life at the end for them, that was really a tragedy that this kind of system would have helped prevent, plus cut down costs in their final times as residents of our city. So I really do support this concept, and I think it's bold and courageous that you're bringing it forward. So again, to that nameless couple out there that I think of often still, you know, this is something that is going to be for someone in the future in that situation to help them, or some family that had a child with pneumonia or such a bad case of the flu around the corner from me in Darby Court who expired. You know, couldn't get her to the emergency room in time, couldn't get her to a primary care physician, and a 6-year-old child died. That's the reality in our community, and if we could prevent some of that, then, you know, let's go ahead and make a go of it.
Councilmember Witt.
Thank you, Mayor. All right, so as I understand this, if we should implement this and roll this out, the city is not paying for people's health care, so I don't think it would be a draw to have people smuggle their cousins in, because they will eventually have to pay for their own care. It's just a way to, it's kind of like a safety net service to make sure that people can have access to care. We're not saying we're paying for it. So, do I have that correct?
You do, Councilmember Witt. What we're looking for here is to connect things that already exist. What we're not looking to do is create a new system.
Mm-hmm. Okay, and so what I hear you saying is our role has been as a convener, which is completely appropriate, and I think completely missed up till this point. So really appreciate the leadership that it took to start down this path. The piece that I see, it's gray for me right now, is I don't understand. So these care coordinators. All right. Are we paying for that? Do we? So we're getting buy-in from the health organizations in the area to chip in to pay for the care coordinators? Grant money. Tell me about that.
The end result on those care coordination teams is they would be full-time staff, care coordination teams. To start on our pilot program, it's existing resources. So it's a social worker for mental health partners. It's a public safety paramedic. It's Salud health coaches. And what we'd like to try to do is prove that the savings that team can generate through the system, kind of bending that curve, gets everybody to feed back into the system to employ them full-time. Mm-hmm. So the intent of these pilot programs is to try to prove the savings to everybody. Mm-hmm. So we can, as a network, all come back together and say, hey, we saved $6, we're throwing $2. We saved $9, we're throwing $3, mm-hmm. and to fund them that way. That's our goal with those teams.
Okay, so eventually, we are just a partner. We're just a partner in a conglomeration, and our piece is just with first point of contact. Our paramedics go in, and that's our piece in the long run, right? And also our social services and our networking with nonprofits like Meals on Wheels and things like that. These are things that we already have in our community, and we're just meshing them together a little bit more tightly. Correct?
That's correct. I mean, but I think it's certainly worth stating that public safety is already a major medical services provider. Mm-hmm. So we're already part of this. Right. So it's not like we're going to be stepping out.
Right.
What we're trying to do is increase the level of connectivity. Is there something we can do with our resources that we're not to try to feed that level of partnership? But you're right. We're not looking to create something new. We're really trying to tie things together.
Sure. And also what I've heard you say is we have chronic users of our paramedic services as transport to and from the hospital. And if we should enact this, that should decrease that number. I've heard them referred to as frequent flyers. They need a lot of help, and if we have the support network so that they don't have to be accessing emergency care all the time, then that number should dramatically decrease. Love the concept, and I really like the hometown attitude of this. We're not relying on other people to take care of our problems. We're going to solve these problems ourselves. And it also kind of ties in with you belong in Longmont, because I think that this is a place where if you're falling through the cracks, we're going to catch you and get you the help you need that's already there. So anyway, I really appreciate your presentation.
Thank you.
If I can jump in there. I think one of the points as we really talk about the discussion we're having tonight, what we wanted to do is bring the concepts out to council. Obviously, there's a pilot program that needs to occur. They're doing more work on each one of these areas. And so as we talked about tonight, it's about presenting information, it's about receiving information, but this is something that definitely will come back to council as we start moving into the next steps and it starts coming together more completely. We bring a complete package together, so that's part of it. As Mike and Dan have both said, we still have more work to do in this process, and so we didn't want to get even farther down the road and not have this conversation, and so that's actually why we're moving through this. So that's why you're not seeing any recommendations. We're just wanting to have the conversation with council in this environment.
I'm a firm believer of stealing models of known, proven things that work. I think that's a great idea. I mean, you don't have to reinvent the wheel. If other communities have done things, and you can pick the proven things that work. So I applaud you for taking that approach. Councilmember Sorry.
I'm not sure that stealing is a term that the police department will ever use. Maybe copying successful models. Model. Great presentation, very innovative in concept. The question that I would have is there some point in the future where we wouldn't be the conveners and one of the other partners would take the lead? I mean, you don't need to answer that right now, but it's a thought process that you might want to consider. And also, it seems like the only, at least from what I gathered, the only way that people would know about this program is if they're already using the emergency services. How are we going to get the word out to other people that may need it and aren't using the emergency services?
That's a great question, Councilman Simori. That's really the role of our Outreach and Education Task Force. That's really what that group is built to do, is try to figure out what's an effective distribution method, for lack of a better term, to get all those things out. Use those informal experts. Use all of the different community touches that we as a city have. I mean, we touch our community hundreds of times a day, every day. Right? Is there a way we can use all of those means to try to effectively educate people about what's out there? That's really one of the key charges of that committee.
Okay. And I think you mentioned that there's not much of an initial cost, or maybe zero, but is that really reasonable to expect that there wouldn't be any implementation cost? I mean,
there certainly will be costs. I mean, the pilot programs at this point do not have any, but to really roll this out, there are going to be costs, there's no doubt. But the hope is those costs create such a level of savings that it's self-funding.
Okay. And is there a projected time frame when you think that might occur? I mean, is it within the first year, within the first 5 years?
It's a good question. What we would like to get these pilot programs rolling, at least started this year, and I think we can do that. And then what we'll have to do is continually, every month when we meet, really try to figure out how's it going. Do we need to tweak? Do we need to turn? Do we need to stop? And really let the process determine the time frame.
Okay. Well, I guess the reason I'm asking the question is that if for some reason it takes longer than expected for the payback to occur or for the cost to decrease, how would it be funded?
That's a good question. We'd have to address that with the network.
Okay.
Well, thank you. Do you think it's?
Also, I wanted to add one more thing.
Sure.
This, public safety has utilized this process informally. And I actually have experience in being involved in some cases, and they have worked with Michelle at the Senior Services Center and Karen's folks on some tough cases, I think, and we've seen some really good results in these specific instances where it occurs. And I think what this is saying is really trying to take that concept at a larger level, and frankly, it reaches into community services. It hit both fire and police. The individual that they were working with actually really loved firefighters, and we found that we were getting some traction there. And so I know they were utilizing firefighters to have conversations with the individual. And so we've seen hints of this, and they do it in these really tough cases. And this is really just taking what they're doing now and really looking at it a broader community perspective. And I wanted to point that out to say that on this discussion, we have seen components of it.
Thank you. All right. Well, thank you, Dan. Sure. Yeah, let's take a 10-minute break.
Yes, please.
Really?
So where do you know Mark Lloyd Street?
Where did Katie go? Oh, okay. All right. Whenever you're ready.
Had some of those in California, but I said, I'm only having them there. And so I haven't that burger with that iced tea. Yeah.
Go ahead, Mike.
Okay, good evening again, Mayor, City Council, Mike Butler, Public Safety Chief. This is a two-part presentation. We're about ready to enter into the second part. It's about the ambulance self-transport system. I want to say a few things before we get started. I know that there's been some conversation amongst folks in the fire department and some concerns expressed about one or two of the options that have been presented. I will just let you know that a couple of things, that we are in conversation with people within our fire department about the concerns that they have. We're going to be having more conversations, and in fact, the deputy chiefs, Dan and I, are going to be meeting with every single crew over the next week and a half or so to get more of their insight and perspective around the concerns they have. The other thing I want to say is I know that one of the concerns that's been expressed specifically is taking the one of the engines out of service. We've made the decision that we're not going to do that, but we are exploring some nuances related to keeping that engine in service and looking at it from that perspective as well. We haven't fully vetted all of that yet, but we will come back when that's done. The one thing I want to alert council to, though, and it's been a concern of mine for a while, and I'm just going to put it out there. This community voted for a public safety tax in 2000, I think it was November of 2006, if I'm not mistaken. And part of what the community was informed about was that if we built a 6th station in the center of town, that response times would be reduced throughout the city. We have been tracking those response times since that 6th station has been in place, and what we have found is that the response times have not fallen throughout the city, and so it remains a concern for us. But on the other hand, it's something that I wanted to alert council to in terms of the response time data that we have. The response time data we have, and that station, by the way, was commissioned in June of 2009, and the response time data we have has been from 2010 through 2013. So I just wanted to alert council to that piece of data, and the data that we collected was collected with the same methodology that we collected the data back in 2006, 2007. So with that, I'm going to turn this back over to Dan. He's going to give you some of the options again. We are not looking for, we're not going to have a recommendation for you tonight, nor are we looking for any kind of decision from council. We just want to give you the information, and then if you have questions about that information, please feel free. But that's the role we're playing tonight, and that's the role we would appreciate if council would play. So with that, Dan.
There we go. Okay. So for this little one, we're going to talk a little bit of background on this, a little bit about tiered response, and then we'll finish up with ambulance service options. And like the chief just mentioned, we're not looking for formal direction tonight. This is about informing you about some things that are going on and to hear what your questions and concerns are so we can come back at a later date. So the fire department, like we talked about before, we are a major medical services provider in this community, and we're asking every member of the network to examine what they do and determine if there's something they can do a little bit differently or a little bit more effectively, and we're no different. We're asking ourselves those same questions, and we ask those questions of ourselves during the strategic planning process that I talked about before. And there's a couple of items that came out of that process in 2010 that we'll talk about here. One of them is tiered response, and one of them is self-transport. So here's just a little thumbnail background on what the fire department does in a year. These are 2012 calls. Now, the big number there obviously is the 5,500 medical calls, 70% of the total. And then the bottom really is to convey the message that the ambulances are busy. You know, the busiest ambulance in the city, I think, runs almost 8 calls a day. They're out longer than the engines are, clearly because they're transporting. So we see the impact. I mean, the impact is on the ambulances. The ambulances run much more than any other apparatus. The current system, currently what happens, somebody calls 911. The dispatcher's EMD the call. It's emergency medical dispatch. Basically what that is they start asking questions about what's going on. You know, they may get a response like, I'm sick, I don't feel good, something's wrong. So the EMD process starts to, is the first level of triage. If it's something like I'm having a heart attack, triage ends pretty quickly and the resources get out the door. But it's a kind of a critical component of this tiered response system going forward. So currently, regardless of acuity, regardless of what the call is, the closest engine and the closest ambulance with 5 people total go to that call. If that patient needs treatment, if they need to go to the hospital, if they need to go anywhere, we have one option currently without alternate destinations, and that's the LUH emergency department, regardless of severity. It's a very reactive system. It's not flexible. So one of the things we're talking about here is a tiered response model. And basically what tiered response is, it's a move away from that one-size-fits-all system. Really what it's meant to do is match the severity of the call with the amount of resources that are sent. So 911 calls are going to get a different response under this system. A very low severity call, you know, whatever the case may be, I have a broken finger, something, is no longer going to get a engine in an ambulance emergent going through the city. Maybe it's going to get just an ambulance non-emergent. The high acuity stuff, we're not talking about messing with any of that. Shortness of breath, chest pain, all those things, clearly it makes sense not to touch those at all. We did a study on this last year. We went through the whole process. We figured out what calls are appropriate. We worked with our medical director, the paramedics, dispatch center, and we have this list done. We have it all in place and ready with all of the different adjustments that would need to be made. What the outcomes of this are, it's tough to tell right now, but some national estimates and some other tiered response models locally, we think it's going to be somewhere in the 10 to 20% range. It's a little hard to tell. So that's somewhere between 500 and 1,100 calls that would get something different than they're getting now. So whether that's just an ambulance, just an engine maybe, it kind of depends on what the call is. And this really fits in perfectly with alternate destinations, because those are the calls we're talking about in this case too. It's the low severity calls. It's the minor calls that we would like to not take to the emergency room. So this really fits in perfectly with what we're trying to do there. It kind of marries up nicely. The cost clearly will be reduced. We're not sending as many people. We're not sending as many apparatus through the city. And then the second piece of this is ambulance service options. Like the chief said, we've talked about a lot of different options. We're not done talking about options. We're still exploring. The options that I'm going to present to you tonight all fall into 4 groups. They're not specific. They're kind of groupy. We haven't explored any options that lose money. That was kind of one of the rules we had in this process. We're not interested at this point in looking at anything that's going to cost more dollars. And again, we're looking for input. We're looking for questions, but we're not looking for formal direction from you. The current model, American Medical Response provides ambulance transport service. They're a private provider. They have since 2007 via contract. Their general manager, Chad Fallenkamp, is also in the audience back there. I'm sure he can answer questions if you have them. The current system has 3 full-time 24/7 ambulances in fire stations right down the middle of the city. There's a shared resource that's a 24/7 resource that's close to 17th and Main. AMR uses that to do some interfacility work and some county calls, but it's our primary backup in case the 3 primaries are already out of service. And then they also provide us with 2 unstaffed jump ambulances that are in stations. Basically, these are full-service ambulances. They're just not staffed. So for some reason, the other 4 ambulances are not available. The fire crews will just jump on those and provide the service directly. As part of the contract, AMR reimburses the city about $100,000 for expenses. The AMR crews work the same 4896 schedule as the fire department does, and they work and they live in the stations with them. There's been no service issues with AMR. In fact, they have been what I would consider to be a spectacular partner throughout this whole thing. They're very involved in the network. When this whole thing with ambulances started to kind of bubble up, the response we got from AMR was as far from negative as you can imagine. The response was, what can we do to help you? What information do you need? How can we do this with you? It's been an incredible partnership with them. So there are no service issues. So options 1 and 2, they're kind of similar. We're going to do this again here. I will work around. So option number 1 basically is not have the city do transport. Basically reissue the existing RFP, status quo. The contract expires October 31st of this year. We have the ability to extend that for a year. We've talked to AMR already. They're willing to do that. But basically option 1 is recreate what we have through RFP. Option 2 is have the city issue an RFP, but with a little different flavor. Add something to it. Change the terms. So this is something that isn't unusual in the ambulance business. This happens. Basically, issue an RFP asking for more. Maybe we're asking for more money. Maybe we're asking for personnel. Whatever the change in the terms may be. And along the lines of this, AMR has already offered up an option that fits under this model. There's any number of different ways this could go, but basically this is continue with a private provider, but figure out a way to rework that contract. Under ambulance options 3 and 4, both of these option groups would have the city providing ambulance transport service. We've done some work on these already. We've done 5-year pro formas that have been through the city finance and budget office. We've worked the numbers as much as we can with assumptions. A loan would be required under this for capital expenditures, but that's been built back into the models. The biggest unknown here, and something that I want to spend a little time on, is the collection rate. The collection rate in the ambulance industry is interesting. We did a survey of a lot of surrounding agencies, and we got everything from 32% to 83%. Our models have a 40% collection rate, and the reason that is so low is, the average ambulance transport fee around here is about $1,300. That's average, but Medicare and Medicaid have negotiated rates. They're going to pay what they're going to pay. They'll pay $400, and you can charge them $2,000. They're going to pay you $400. So that big gap in there is uncollected revenue. All the other insurance providers do something like that, maybe a little bit more, depending on what it is. Clearly, somebody who's uninsured or private pay, AMR is not going to get much from them, if anything. So that entire bill is uncollected. So it isn't kind of your traditional business model where something costs $19 on a rack and you get $19 for it. It's a very fluctuating rate, goes up and down. With the Affordable Care Act, we're not sure what effect it's going to have, but that is a key thing to both of these models. There's going to be at least a 9-month implementation time frame, no matter under anything related to 3 and 4. And we built that talking to Sandy's group, all the shared services people. How long is it going to take for us to order ambulances? We'll have to issue an RFP for a billing company. All the different things council will have to do along the way. We built out a timeline. So at whatever point we make a decision, it'll be at least 9 months from that date before we can actually provide service on our own.
Councilmember Santos.
Thank you, Mayor. Dan, why would we need to issue or go purchase ambulances? I was under the impression when we first went with AMR, the reason we went with AMR at the time that it was discussed with me, with Chief Trunk, was that all the design, all the gear, all the medical gear that we required of AMR was that if we ever went
to self-ambulatory service, we could just purchase those outright. Why would we need to buy new material?
That's a good question. I don't know the details of that contract. I'm under the impression that currently AMR owns everything. And it's my understanding that unless they pulled up stakes and just took off, then all this stuff would revert to us. But I believe we have spec'd it and said, here's what we'd like you to order, but they own everything now. So if they go, their stuff goes. I can certainly clarify that with a couple
I'd like
of the
some
experts
clarification
behind it.
because I was under the impression that if for some reason that if we decided to go to self or they left, we could purchase them. We could purchase.
Mayor Pro Tem Santos, that is a possibility. That is an option to consider. There's no question.
Okay.
You'll find that answer for sure.
I have a question.
Councilmember Finley.
Do you know what percent of the people transported by ambulance are Medicaid patients?
I do. The mix is at about 46% are Medicare, Medicaid.
So 46% are paying, or through Medicaid, around $400.
Yeah, yeah.
And I don't know if you've heard this, but I have heard that the rates under the Affordable Care Act will be similar to those of Medicaid, the reimbursement rates. Is that how you figured that also in your modeling?
We used the exact numbers that were collected this year by AMR. So we used those numbers we're actually fairly confident about. We used what is exactly going on, and we projected a flat rate. We didn't project changes in that because I don't know really what the Affordable Care Act will do. More people will have Medicaid, so there will be a drop in the number of uninsured, but I don't know if the Medicare Medicaid rates will go down enough to compensate for it.
Yeah, I think that's a big unknown, really.
It is an unknown, and there may be many more people who are now getting insurance from their employer as well. It may not fall under the Medicare, Medicaid.
And I think part of it so I have been in this world to a certain extent where you set the billing and the cost, and so one of the things that we did in my previous life is you base it off of, so you go in and you establish rates on Medicare, Medicaid, because you have to hit that. But then what a lot of cities also do, and then you get into the nuances of each state, is you actually have different charges for different types of service. So you may have a basic fee for ambulance services, but then you may also have a different fee for more advanced life support services. And so there are a lot of nuances into that model in terms of what you look at and what you put in place that can change some of those numbers. And then the collection rate, to kind of talk about the differential, can also depend on what, from a policy perspective, is decided in terms of how you collect those rates. Some policy boards will say you send one bill if you can collect on it, great. If you can't, then you don't. Others will say you take more of an aggressive approach on collection. So a lot of that is also dependent on how you set that process and what you're willing to do as an organization. So there are a number of variables that it's not just about collection. It's about what are the policy statements that are guiding the collection process that can impact that collection rate too.
I had another question. That brought up another question. You said more people may be covered with their employers. That's really not what I'm hearing. I hope that's true, but I can't think of my other question. I'll have to wait.
Okay, I guess you can continue with your presentation.
Okay, so continuing on, this is option 3. So under this option, the city would hire non-firefighter, EMT basics, and EMT paramedics to provide the transport service. Basically, the idea here would be to replicate to the extent we can the system that's in place, but it would be with city personnel. As you can see, that bottom line net income for year 1 is razor thin. If any of our projections are a little bit off, it could go in a bad direction there. Option 4, this is basically a group of options that would reassign city personnel to offset the number of new hires. So obviously this reduces the costs greatly. That's why that net income number is much larger. There's any number of different ways that we could do this. We're still talking about these, and the net income would really vary based on implementation. But the reason that it's so much higher is because essentially we would hire less people. That's really the only change between 3 and 4. And then what we would actually do with the reassigned personnel, and the chief talked about that a little bit. So briefly, in conclusion, again, we're a direct medical service provider. We're part of the network. We're investigating ways that we can support the network and provide a higher level of service to our community, which we constantly do. That was the whole reason we had a strategic planning process. Can we use this in some way to support our community with community paramedicine, fire station clinics, health portals, any other activities with our current on-duty personnel? We're always open to new ideas. We're going to continue to examine everything. And again, we're here just to inform you of what's going on and get some feedback and answer your questions for a later date. So with that, questions?
Councilmember Simone.
Thank you, Mayor Coombs. So if I'm understanding the presentation correctly, if we were to become the service providers ourselves, not only would we save money, but we would make money?
Well, depending on how we implement this, there's a possibility of overall system savings.
Well, that was going to be my next.
We would like to refer to it as generating revenue that we could repurpose as well.
So the net income that you're showing is after you pay for all the ambulances and equipment that you need.
Correct, and there are detailed 5-year pro formas in your council packet. They're in the back there to have it all laid out, and those numbers have all been through Jim Golden and his staff too.
Okay.
So as Dan indicated earlier in his presentation, the one critical piece to this is the assumption on the collection rate. And so if Brian were here today, he would ask Jim, what's your thought? And that is, if the assumptions are right, it works. And that's why I think we're saying we're still working this and still looking at it, because those assumptions are critical in this discussion. And that's why they're still working and looking at the numbers.
I would like to add to City Manager Dominguez's comments that last option in repurposing our personnel, we feel pretty comfortable that even if the collection rate remained the same or real close to that we would still be generating revenue that we could repurpose.
Councilmember Witt.
So, if I'm understanding correctly, we're not talking about hiring any additional staff if we were to go that route, because my concern is our largest line item is staff, and if we're adding staff, we're paying for 401ks and everything else. That's a concern that I have. And is that factored in to the pro forma? Yep. All right.
Yes, it is factored in. And the other, I don't believe Dan said this, the other thing that happens if we take on the ambulance service is that more of the money stays in Longmont. Right now, the money that people pay for ambulance service basically goes to MR. And so if we were to run our own transport service, we might be able to employ more people from Longmont, more money might stay in Longmont. And we also believe that overall, given our capacity to control and manage this response, that we could increase the level of service, the quality of service.
Councilmember Santos.
Thank you, Mayor. And where's that $480,000 going?
So that would be if in fact those dollars were realized, that would be our part to put into discussion with the network on what can we do with cost savings. So that's our version of bending the curve. So that's the network's chance to come back to us and say, let's reinvest that back in.
You go first, I'll go second.
There is a major connection here between the network and this ambulance transport plan. If we in fact had people under our employment running the ambulance service, community paramedicine in those health clinics, we believe, are easier and more possible to do because we don't have to contract or negotiate with a private ambulance service to try to figure that out. And so that's where that's really becomes helpful, and that's where a major connection is between these two concepts.
Well, when I look at option 3 versus option 4, just as a finance business guy, option 4 seems like it's got a lot of potential. Even if you're off by a considerable amount in your collection rate, there's a lot more coverage, or the bottom line numbers are so much better that it still looks like it's really worth taking a strong look at. My estimation. Councilmember Santos.
I'm sorry. Did you have something, Harold? I still have another.
So actually, to answer your question, obviously, that would have to come back to the council in our budgetary processes and for any expenditure for those funds. So, the council would be involved in that process. One of the things that we're talking about now with some of the other partners in this is what happens if you save $500,000. Is there going to be room and discussion, and how is that repurposed and how it goes into the overall system? So frankly, this is not just about the city, and if we can save money, this is about everyone involved in how we can bring those dollars to bear for the benefit of the community. So again, that's still an evolution in the conversation and the discussion that we're moving through.
Just waiting to see if someone else had a comment before I ask my next question. Just a real quick question. Did you have something else, Mike? Okay, Dan, when is the tiered response looking to be implemented? Or Mike?
Mayor Pro Tem Santos. Last week, I gave direction to Deputy Chief Van Landingham to start implementing tiered response. There's quite a bit that we have to do in terms of training our dispatchers, ensuring that everyone's aware of what's going on, and resequencing how we do our emergency medical dispatching. But the process has started.
Okay. The one thing I'd like to see is something we do get. Building Development Services does this for us, and it might be interesting to see each quarter, see how the tiered responses are being done, maybe just an information item in our council packet to see how that is being implemented. What might be useful for members of the council to see how this new system is working.
Will do.
One of the things, if I can add, I actually had the opportunity to attend an ICMA meeting, Mountain Region in Denver. And there was a county manager from Sandy, maybe Wichita, and he was talking about what they were looking at in terms of their tiered response model, and I mentioned it to Mike to actually look at too, because they've gone as far as using what they call as a PIP crew concept, and so they've broken down certain calls into where individuals have certain points, and their data was actually showing in terms of survival rates tremendous differences in it. And so I'm kind of mentioning that to Mike to say, here's something else, and here's a group that's doing something pretty unique.
Well, Marion, I think you drive a good point regarding the ambulatory option. Looking at numbers, it does look good. I'm just worried about the implementation. So while I know this contract ends in October of this year, my concern is implementation of how fast and furious. If we were to go with at least option 1 or 2, is it a possibility to do a 1-year contract? Are those an option with looking at potentially going in, working a process? And I know you're going to be having meetings, Mike and Dan and the deputy chiefs. Is that a consideration, doing a 1 or 2 year contract with AMR, knowing that we're potentially going to a fully city wide ambulatory owned system?
Yeah, it is. And we've already talked to AMR about that exact proposition. We have the ability we can extend their contract essentially for another year, the existing terms. We can't change the terms. But under any of these options, with the possible exception of option 1, we would need to do that, at least to some degree.
Okay, thank you.
Councilmember Samari.
Thank you, Mayor. So when somebody calls and you question what their ailment is, you're going to basically decide what to send based on the information that they give us. If they don't give us the right information, what's our risk in terms of legal liability? If you send somebody because they said they have a cut on their hand, but they're actually having a heart attack, for example.
Couple thoughts on that, Councilmember Samori. First, there are some caveats for us. First of all, if the dispatcher, after receiving the information, still believes it's unknown in terms of the nature of the ailment, we'll side with sending an engine and 3 other personnel. The lieutenant, another caveat is the station lieutenant can also override the call and also send the engine as well. If the AMR, or if the ambulance gets there, and realizes that's a different kind of call than what they originally thought, then they can also send the engine. So those caveats are there. We have checked with the city attorney, and we do not believe there is a major liability. This is being done all over the country too, by the way. This is not something new for Longmont. So.
Councilmember Levison.
And to follow up on Councilmember Samori's comment, with the first presentation we heard from you, Dan, by the address, we would, the response would know whether or not you'd been there before. The dispatcher may be familiar. And so the other nuance is that having been there, maybe having that network closer coordinated care connection, you would have a better chance of judging to a more fine-tuned sense is what I'm trying to see the result of the first part of the work you introduced us to as to the cost savings in the second part of this kind of work. So I see you nodding your head. So that's I just wanted to point that out. And I think that what's going to be the big we need to iron out some of the unknowns first. How much is going to be the reimbursable rate, and if the reimbursable rate depends on additional services you provide besides just transportation, emergency transportation, then that's something that we'll know in the next year or so.
All right, I don't see any further questions from City Council, so thank you very much, Dan and Mike. Would you like to make any closing remarks?
Thank you.
Thank you. Well done.
Mayor, the last item on your agenda is a presentation on the Lodgers Tax Fund balance used by Sandra Cedar.
Mayor Coombs, members of council, Sandy Cedar, Assistant City Manager, and I'm here to discuss the Lodgers Tax Fund balance. So just a little bit of history. You may remember during the last budgeting process, you voted to go ahead and move. Sorry. You decided to go ahead and move 100% of all lodgers' tax monies that was received by the city to visit Longmont in order to be able to program the way that they saw fit, and required for them to have their own grant funding program that they would be able to administer. They're in the process of administering that grant funding program. My understanding is that they were making decisions this week on where that money may go to. But in the meantime, what was left behind was a fund balance in the lodgers' tax fund. And so most of that money is really from that first year of the lodgers tax before Visit Longmont really kind of got up and rolling. That's where the significant amount of this. And I should tell you that after the packet went out, Teresa Malloy, our budget manager, told me that it's not $144,000 that's in the fund. It's more like $174,000. I mean, $114,000 that's in the fund. There's less money because Visit Longmont actually received their last fourth quarter statement from the last year. So I wanted to tell you that. I think I've got that right. And from that point forward, what we started to take a look at is what should be done with the remainder of the fund balance and the lodger's tax. Of course, there is an option that you could do nothing and let it sit there, but there is a requirement by your code that basically says that all revenues from the lodger's tax established by this chapter shall be placed in the lodger's tax fund and used by the city for promoting tourism, conventions, and related activities and acquiring related facilities. No part of such revenue shall be allocated to the general fund or to the public improvement fund. So I wanted to tell you kind of what the restrictions were around this money. Once we realized that this fund balance was there, we had discussions with the city recreation department, with the LDDA, with Visit Longmont Board, economic development, and myself to talk a little bit about what should we do with these funds. Traditionally, the tourism grant funds had been used to fund the summer concert series that you see downtown. And so one of the thoughts was that we could use some of this money, which you see in the proposal that we put before you, $45,000 as a lump sum, to be able to give to the summer concert series in order to sort of wean them down from what was currently given in the tourism fund. So this would be for 3 years of the various concerts. Those concerts cost between $20,000 and $30,000 a year to put on. With the remainder of those funds going towards monument signage. So just to be clear, we're not talking digital signage, we're talking stones and things like that with some lighting that really would illuminate and really tell people when they entered Longmont, when they came to visit Longmont, that they were in Longmont. And so this proposal is a culmination of discussions with all of those different groups, and so I'm here today to bring you that recommendation as well as to let you know that if you approve that, you'll be seeing an appropriation for this year. One of the things that was part of that was that the summer concert series was not appropriated in the budget system because of this change of the lodger's tax moving over. And so you would see an additional appropriation on June 25th for the concert series in this year, if that's what you chose. All the other things would happen as appropriations during the normal budgeting and CIP cycles. So with that, what questions can I answer and how would the council like to proceed?
Councilmember Santos.
Thank you, Mayor. Sandy, you said there's 114?
Let me take a look back at that. I wrote it down because Teresa told me again. It was less about $25,000.
Because, yeah, the lump sum in the 99 is not going to add up.
No. The lump sum would need to stay 45. Whatever is the remainder of the balance, the recommendation would be to go towards the signage, whatever that looks like.
Okay.
She told me what it was, sorry.
I just want to make sure.
It's about $25,000 off of that, was what the last Visit Longmont received.
Okay. Thanks.
Councilmember Levison.
Hi, I did do a check-in with Joe Ward, who's the director of Visit Longmont, and brainstorm a couple of things. But one of the things that I really would like to see is whether or not we can't offer something out of this, the balance of the money, the approximately $75,000 that might just be a little perk for people that come and stay. And the idea that we had spoken about is to have a number of passes to our pools, a rec center, or to some activity, maybe Union Reservoir even, for those people who come and stay 2 nights or more, just as an extra kind of a perk, and see where that takes us. It just seems that in my personal experience, when we've had family come in from out of town and come and stay the weekend or visited, that it would be a great thing to have a little bit of an extra that can be used to get people out there using our great facilities. And especially since we've got a lot of the softball tournaments and other groups coming in where there'll be both parents and other siblings in tow, it would be a nice added benefit. And it's stuff that, frankly, people do remember. And I talked to Joe about it, and even if we did it on a trial basis and figured, to set aside a couple of $1,000 is what I was thinking to see if we can't initiate something and see what the response is too, to test it out. Just something a little bit new and different. So my suggestion is we may take maybe a total of $3,000 of that balance that has been revised down to 75 and see if we can't do something a little innovative to actually give the money back to people that are coming and spending their money here. And then, we might get a great feedback about our facilities as well. And that would be useful, I think, for the community and the staff. So I guess in order to get discussion going, I move that we set aside $3,000 of the remainder for a program to give some free passes for swimming pool and rec center to our visitors who stay 2 nights or more.
Councilmember Samori.
Thank you, Mayor Coombs. The way this...
There's a motion, right? So it has to
Yeah.
be there.
Yeah.
Second.
Yeah.
It has to be now. If anybody's going to second it.
Okay. I guess I'll go ahead and second that. I've got some reservations in how it would be administered and how much money would be wasted in the administrative cost of that. But if there's a clever way to do that, I'm all for anything that promotes kids and health and swimming. It's not a whole lot of money that we're asking for, so I would support that. So I'll second Sarah's motion.
Mayor Coombs, let me just clarify real quick. So of the $144,000, the last piece of $27,000 was given to Visit Longmont this last month, which takes the total to $116,656. If you take out $45,000 for the concert series, that leaves the balance at $71,656. And I apologize; those numbers came in after we had given out the agenda. I apologize.
So do we have an estimate or a quote on what the signage is going to cost?
Mayor Coombs, Councilmember Samori, we do. We did a set of quotes last year to be able to put it into the CIP process. The quotes came in between $20,000 and $30,000 per sign, and that included design. So if we assumed $30,000 for the first sign, which includes the design, and we repeated that design in a couple different areas, I would assume between I've been assuming $25,000 a sign if you do more than one.
Okay. And I know that this topic was discussed extensively at the board meetings for Visit Longmont, and everybody was in favor of allocating the money the way it's been recommended. And in my conversations with Joe earlier this evening, he has the ability from his fund to be able to do the promotion that Councilmember Levison is suggesting without taking any money out of the allocation that we're discussing here. So if he's willing to do that out of his regular budget, I would recommend that we just go with what's allocated here already and let him deal with the other on his own. And I also suggested to him that he might want to work with the hotels and other visitor-like organizations in Longmont to see if they would be willing to do promotions to get the people to stay longer at their facilities.
Mayor Coombs, I should mention that Joe is here if you had any questions of what was discussed in his board.
Councilmember Witt.
That's great information, Councilmember Samori. What I was going to say was that it sounds as if the plan as it was presented has been run through several bodies and has come out as being a good solution. I always appreciate Councilmember Levison thinking outside the box. So I'm glad that her idea would be able to be implemented without having to discard the work that the different groups have already done. So I'll just leave it at that.
Councilmember Larson.
I guess my main question is that, if Visit Longmont already had the capacity to do this kind of promotion in their budget, nobody actually thought about it before today. And so this was not an idea that the board ever considered. So, I just don't want to, if everybody thinks it's a good idea, I don't want to burden Joe's budget, this year with saying, oh, the council would really like to see this because this is money that we can allocate, rather than, I've heard council members not wanting to direct Joe about how to allocate his budget, then say to him, we really want to see this kind of promotional program. So I think I'm considering this kind of found money and thought, oh, well, let's see if we can't do something fun where, Joe's board may not support him in saying, oh, well, let's try something fun and new. And here's an opportunity that we can help him out and maybe get some response on from visitors to Longmont about using our great facilities. And so I just thought it might be a good way to have a pilot program without Joe having to sell a pilot program and just see how it works. And since, his board hadn't taken up on it, the council, it's just kind of a unique way to look at us promoting our own facilities. And that may not be the direct mission of Visit Longmont, but it certainly is our mission.
Councilmember Witt.
So you come up with an idea today. It hasn't been vetted. I just don't think it's a good idea.
Councilmember Santos.
Thank you, Mayor. Well, just having returned from well, not really a vacation, took my kids
Sorry.
to
say it was wonderful.
it was a wonderful, magical experience at Walt Disneyland. And while we enjoyed our time there, I ended up paying for everything in Anaheim. I can't think of whether I wanted to go use a city facility or not. And they had nice facilities, I'm sure. We make our residents pay. We make our employees pay. Everyone is treated equal. The first item on our agenda, one of the items that we said we didn't really like was someone, a group was suggesting that perhaps we should set aside looking at a fund to set aside to give perhaps some money to those groups that didn't want to pay for usage of closing down the streets for the Longmont Emergency Unit or overtime for hiring police department. Wherever you go around the country, whether you want to go into a theme park, a pool, most hotels have pools. Joe, I would just recommend talking to the hotels. If there's something that everyone would like to do at Visit Longmont, excuse me. It's ingrained. That they would like to promote city facilities. If there's a way that we can help them, so you belong in Longmont, you belong at a city facility. If there's a way that we can help with a $1 off or something of that nature, come back and talk to us. But at this time, I'll stick with the recommendation that we have here.
Well, since we only have $71,000 left to pay for $75,000 worth of signs, it doesn't seem like we have a whole lot of wiggle room anyway, because the math just doesn't add up anymore. So,
Mayor Coombs, that is true. And again, as we kind of worked through this, we were using the last CAFR numbers on this and didn't realize necessarily that the last one to Longmont had been cut. So I certainly apologize for that. And we will use all of our negotiation skills in order to make $75,000 fit into 71.
I trust you'll do that.
That's the decision of the council.
So we've got a motion. I guess we need to vote on the motion that we've got. So let's vote. Okay, it fails. We have 4 dissenters, Councilmember Santos, Mayor Coombs, Councilmember Witt, Councilmember Finley, and Councilmember Samori. So it goes down one to 5. So does someone want to make a new motion? Councilmember Santos.
Thank you, Mayor. I move that we go with the recommendation as presented.
Okay, let's vote. Okay, that passes 6-0 with Councilmember Bagley absent.
Thank you, Mayor Coombs and members of council. The next step is that you'll see the additional appropriation for the concert series at your June 25th meeting.
Okay, thank you, Sandy.
Thank you.
All right. So now it's time for mayor and council comments. Councilmember Samori.
Thank you, Mayor Coombs. Since we didn't have a meeting last week, somebody that's walking away had a birthday on the 25th of May, and I think we ought to kind of sing her happy birthday twice.
Twice?
Who? Sean who? Sean Lewis. How did she find out? And I couldn't get it out of you. So, Sean,
Sandy.
you have to come down here and sing your own happy birthday, buddy.
That's kind of odd. That's creepy. Yeah, that is a little creepy.
All right. On 4.
Happy
birthday to you.
Happy birthday to you. Happy birthday, dear Sean and Sandy. Happy birthday to you. Oh, it should. We should have a proclamation.
Councilmember Finley.
Thank you, Mayor Coombs. I have 2 things tonight. First is my business of the week. Coe's Asian Bistro at 1325 Dry Creek Drive is an excellent place to go to dinner, and I would highly recommend that. My second thing is I still am concerned because there is an injustice in our city. There are some developers who are required to put in pocket parks and also charge the complete park fee, even though they are paying for their own, are required to pay for their own park. This disturbs me, and I don't have the solution, but I would like to make a motion to direct staff to return to the city council options to remedy this duplication of payment for parks on the part of our developers, and bring us those options so that we can remedy that injustice. Do I have a second? Second.
Okay. Councilmember Levison.
Well, if we're going to do that, we might as well give every single homeowner who has a backyard the credit for a park too. You have to have some, you have to have 20% of the lot is open space. And so you can consider that recreating space also. You know, I think this is a much bigger discussion. However, when you talk about injustice, there are a lot of people that are paying for things, and you know, there's a kind of the discussion is that a little bit of an opportunity for some open space on a multifamily property is absolutely justified, in my opinion. Just in the same way that our code requires 20% of a lot on a single-family home has to have, you know, some breathing room. And, you know, it's that's just my opinion. I'm not going to be voting for this motion.
Question, at what level does a developer have to do a pocket park or community park? Is it at 200, or what's the number of, you know what that is? Okay.
No, we'll have to get back with you.
All right.
What is it?
200 units. It's 200 units.
We're
Okay.
hearing 200, but in terms of the specific number, we'll have to get back to you on that. with that answer.
Well, the reason why I bring that up, I agree fundamentally that, there's some injustice and we need to figure out what we might want to do, perhaps. But I'm also concerned, let's say a developer is going to develop a 201 unit property, he has to put in his pocket park, he has to do it. Now, someone that's building 199 doesn't have to do it. But if that person that built the 201 pocket complex had to build this pocket park, well, now he's got, and let's say he got full refund and didn't have to pay any park fees. Well, then he's got an unfair advantage against this other guy who, because he's got more amenities to go along with his unit. So we need to be careful that that we don't overcompensate. I mean, that's why, I think it's good the way Monty worded the motion, that we just look at options at this point and not, decide on anything tonight. You guys can tell us if there's some other ways that might be fair. So I agree that it's something we can look at this point. Councilmember Samore.
Thank you, Mayor Gooms. I think, if my memory serves me right, that for apartments, at one point, we decided to charge less per door than a home, right? Mm-hmm. So we need to take that into the equation as we're looking at what would be fair.
Okay. Well, I guess we've got a motion. It's been seconded. Any further discussion? If not, let's vote. Okay, it passes 5-1 with Councilmember Levison dissenting and Councilmember Bagley absent. All right. Councilmember Wood.
Thank you, Mayor. This past week, I was able to participate in the first joint technical and policy group committee for the Northwest Area Mobility Study. I want to keep you guys up to date as to what is going on there, and I just want to know how you would like to receive that information. Would you like an email? Would you like a little blurb now? Would you like me to do a video presentation that you could just watch? A YouTube video? So I'm just asking, I'm not prepared with enough detail to give a presentation this evening, but I do want to make sure that everybody understands where we're at. So please give me your feedback.
Email's fine with me. Councilmember Santos?
Thank you, Mayor. City Attorney's email are right for informational items like that.
Mayor and Council, for open meeting purposes, I think sharing information is fine. It's the discussion that's not.
Oh, all right. Okay. Do not reply at all.
Okay.
Tomorrow night, which we're coming close to tomorrow anyway, Boulder County Consortium of Cities just happens to be here in Longmont, 6:30, study session room, or in chambers. We are... Sandy, actually, it says me, but Sandy's going to be doing a presentation on engaging the public. One of the consortium board members heard about our telephone town hall meeting and how we engage public in various ways of technology, and we're going to be having a presentation. So if you're not doing anything tomorrow at 6:30, please join us.
Councilmember Levison.
Yes, I just wanted to respond to Councilmember Witt's query about how we want the information. I actually enjoy when people give a verbal report, because we run the risk of responding to you or hitting all and then starting this conversation. It's really hard to say, well, what did you mean by this? And to sit there and, we can ask follow-up questions in this kind of a format. So I actually prefer this rather than, something written. Certainly Phil has probably, if we have a staff member going with you, they'll have some notes. And it'll maybe help out a little bit if you just do it verbally so that we could ask questions about how the process is going and your sense of some of the issues too. So I appreciate a verbal update.
Councilmember Swan?
Thank you, Mayor Combs. I think if she sends us the email, we can read it, develop our questions, and when we meet next, we can grill her.
So what I'm hearing is YouTube video. That's what I hear, right? I'm joking. But what I will do is I receive emails, all the emails that I receive, I will forward to you. You can choose to read them or not read them. But at least everybody has all the information, okay? And Sean Lewis has been going to those meetings as well as Phil, and the mayor is going to be swapping out with me at times as well. So just so you know what's going on.
Okay, well, I would like to do a shout out for Sheena Canner, who's actually taking a leave of absence because she's going to have a baby in a week or two. She did. Well, awesome. Awesome. Boy or girl? Awesome. Yeah. But the reason I wanted to give a shout out is because she kind of browbeat me into doing the Longmont Triathlon, which I haven't done for 3 years. I did it like 27 years straight, then took a 3-year leave of absence, but she wanted to make me a poster boy for health and wellness, and I forgot how much fun that race was and how much fun it is to race, so thank you, Sheena. So, anybody else? Wow. City manager, any comments?
No comments, Mayor Council.
All right. City attorney, any comments?
No comments, Mayor.
All right, this meeting is adjourned.